Hey, good morning, folks. Why don't we go ahead and get started? The meeting's called to order. I'm going to be hosting today. Sue Birch is at her daughter's wedding in Colorado, so we have allowed her to escape the agency for a little bit while our agency work must continue, though. So I'm Lou McDermott. I'm the deputy here at HCA. Welcome to the first of two June PEB board meetings. Our meetings this year are going to continue to be hybrid. HCA staff will be on site. Board members and other attendees have the option of attending on site or via Zoom. For our Zoom attendees, our opening slide has information on how attendees can turn on closed captioning subtitles. Do a roll call. We'll start with Sharon. Harry. Present. Elliot.
Present.
John. Is John with us? We do not see John at this time. Is Kurt with us?
I am present.
Awesome. Kurt. Is Tom with us?
I am.
All right, Tom. And Michaela, I'm told, will not be with us. All right. And Michael Tunick from the AGO. Good morning. Good morning. All right, with board members attending both in person and virtually, it's helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are any questions. Board members attending virtually, we're going to be watching for your Zoom hand. There's no resolution scheduled for action today. The public will be able to provide general comments at the end of the meeting during the public comment period. And as a reminder, if the public has questions during the staff presentation, the presenter's contact information will be included at the end of their presentation. The public is welcome to email presenters during the meeting to capture your question, and we will respond after the meeting. Dave, you're going to go over today's agenda.
Yes, good morning, Chairman, members of the board. We will have you approve last meeting's minutes, and then we'll jump into several presentations. We have the second presentation on the property casualty insurance topic and criteria that could be used to evaluate those types of benefits in the future. So John Part will present that and also tee up a resolution, hopefully for action at a subsequent board meeting. Then we have about an hour dedicated to talking about kind of the structure of pharmacy in our plans, in the Uniform Medical Plan. There are always a lot of things to demystify for ourselves, for you, for the public. And so we took a grand effort to try to demystify a variety of aspects of pharmacy, an ongoing effort for all of us. And I think Jenny and Ryan have done a great job to bring you something to help kind of work through some of the more esoteric parts of the pharmacy benefit and pharmacy structure. Then Ellen will be with us to talk about the status of some parts of the Medicare portfolio. And then Stella is bringing back, it's unusual that we bring you eligibility type resolutions in the month of June, but Stella is with us to bring two more resolutions that we've identified during the implementation process for the Part D transition for UMP class of Medicare that we believe are necessary to shore up some of the edges of the eligibility framework. So Stella will walk through those, and then we'll ask you to take action on those at the next board meeting. And then we have an all-important executive session where we continue discussions on the rate development process for both the Medicare and non-Medicare portfolio. We are anticipating that we will bring rates to the public at the next board meeting, but we have some additional proprietary aspects to walk through with you in executive session today. Last but not least, if we have an emergency, we're going to walk casually across the street. We're not going to run, as I said last week, to the visitor parking lot. And if you need restrooms, down the hall to your left. When you see elevators, look to your left. And that's what I have to hand it back over to you, Trevor.
I think we need to continually refine that. I think maybe we walk with purpose. Casually stop there.
Yeah, we're not going to run, and now we're not going to be casual. We're going to walk deliberately and appropriately speed.
Does anybody have any questions for Dave? All right. Today we're going to go ahead and vote on the meeting minutes from our last board meeting on May 9th. The minutes are behind tab number 3. Are there any comments from the board? Do I have a motion to approve the minutes as written?
So move.
Is there a second?
Second.
All in favor, say aye.
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 All right.
Any opposed? Hearing none, the May 9th, 2024 minutes are approved as written. Dave, follow up from last meeting.
Yes, Dave Eismayer again for the record. I have two things to update the board on. One was a question that came up at the last board meeting as Katrina from our IT department was giving an update on benefits 24/7, its launch and the various issues that are being worked on to stabilize that system. There was a question about, I believe it came from John, about the some issues that he had experienced or knew were experienced for some retirees, I think at the University of Washington, and having trouble enrolling in the system. And when we look back at the data, there was a piece between February and March where if somebody is moving from employee to retiree status and they haven't been fully terminated in the system as an employee, they can't be picked up as a retiree. They can't initiate their retirement and benefits 24/7 at that point. So there was a solution that was patched, that's all fixed, but it impacted about 40 individuals in the months of February and March. So that's an example of something where we learn about an issue, we try to find the root cause of it. In this instance, it related to how the system was accounting for the anticipated or future termination date, and then short that up so that there would be a faster turnaround for retirees who are transitioning to be able to pick up their account essentially and log in as a retiree and initiate things from their retirement account. So that's what that particular issue was. And then the second I wanted to update you on, if these are always in the news and I just try to highlight them, is the Primera multi-care negotiations were successful. And so the notice that had gone out to members about the potential network disruption that could have happened on June 1st was rescinded. The parties reached agreement around May 23rd. As a reminder, that could have collaterally impacted some members in the Uniform Medical Plan, both the non-Medicare enrollees and the Medicare enrollees on the east side. Multi-care is primarily in Thurston County, Yakima County, and Spokane. It would have impacted the Spokane region. Because of how network contracting is, Regents has direct contracts with multi-care for Thurston and Yakima counties, but not Spokane. They leverage the network arrangement that Primera has on the east side in Spokane. And so that's how it would collaterally impacted UFP. Normally you might hear of a negotiation, you might not intuitively go, oh, if there's a Primera dispute that's happening in the public, that doesn't impact your portfolio because there's not Primera, and it doesn't, none of these network disputes are related to Plan F or Plan G. So you might not naturally think that there is a relationship, but there is this leveraging of contracts roughly on the east and west sides of the mountain. And that Regents piggybacks off through the Blue Card Network, Primera's contracts. I say the east side, but that's not perfectly aligned with the Cascades because Yakima County is obviously east of the Cascades, but Regents does have contracts in Yakima County. So, but if you hear about Primera disputes that involve providers on the east side, that should be a hint to you that there might be something in UMP, and then we'll be communicating more about that to members if that happens. It's a pretty unusual confluence of events. I almost didn't say confluence because that's a system on the east side, but it's a unique set of events that comes together wherever where that situation comes up. It did come up, but the good news is, yet again, there was success in the negotiations, so no network dispute actually happened. It is a continued troubling trend that we are seeing more and more and more of these provider network disputes coming out into member termination notices. We are beginning to work on more anticipatory communications to members. We put something in our May newsletters to try to help people start to understand you might get one of these notices one day, because to us at the Healthcare Authority, we've walked through this scenario 4 times this year already. But for the member, they might experience it only once. They may have never experienced it before, and a lot of people are not moving provider systems, hospital systems, or providers, so they may experience it only once ever, once every 3 years. It's not a very common event to them, so it's very understandable that they get a notice. They say, "Oh, my provider is going to be terminated." Maybe they don't necessarily have the knowledge, experience, or understanding that many times the network agreement is reached before termination would actually occur, but they are getting a notice in anticipation because state law requires that there be notice in case there is an actual termination. So it's a very, I know, frustrating experience for members to get those letters, be worried about whether they need to reschedule care, will they be able to switch plans, but we all kind of stay the course. Parties are usually still in active negotiations, and most of the time, at least in recent history, an agreement has been ultimately reached, so there hasn't been an actual network disruptor. But we are trying to work on educating members about this phenomenon, so that if and when one day they get that letter, they might go, oh, I kind of remember there was something about that, or, you know, they have a shot at maybe having a little bit more understanding of what this entire topic is about. So those are the two things I wanted to follow up on, but Elliot, if you have a question.
Yeah,
You went the other way, you need to turn back on.
There you go.
thank you.
I'm here for you.
I get questions about this sometimes, and often I find it so helpful when you do you know where I'm going with this, when you do a presentation, that I can then say to them, you know, they explained that at X meeting, I'll send you a copy of that presentation. Is it too much to ask to maybe do a short presentation about the leverage system and the situation, since it keeps coming up?
Yeah, that's a great, we can put that on the docket.
It doesn't have to
yeah.
be this year, but.
Yeah, it could be next
just-
season, but yeah.
But
we
then
can
I
put that.
have something to show people.
Yep. That works.
And I remember sometimes better when I hear it. So I would appreciate that.
Yeah, we can put that on the to-do list for a future point.
Any other questions for Dave? All right.
I
Our
did
first-
see Kurt, your hand was up for a bit, but maybe I answered your question, but just wanted to check in with you.
Yeah, I was gonna ask a question about the new benefits system, and then I thought I'd just email you, but you know, now that you called me out, I might as well ask you.
No worries.
You know, we've been getting contacted from our members, including ones that work in payroll offices at state agencies about the new benefit 24/7 system and having some serious difficulties. And I know with any new technology, there's going to be bumps and things to work out. So we're telling them to be patient and that HCA is working on it. But I wanted to confirm that. They're telling us that people are dropped for no reason, just randomly, or disruption in their service because something isn't getting done on HCA's end. They're just giving us all kinds of examples of issues, and they're getting concerned. And so I just wanted to raise that issue. I've tried to reassure them that it's being worked on. So maybe you could just touch on that. That would be very helpful. Thank you.
I can confirm that, yes, there are concerns at different parts of state payrolls throughout the state. We are also hearing that. And that, yes, we are continuing to work on various stabilization pieces. One of the challenges that we have had with the system is there has not been, generally the issues roll back to one primary issue, which is the syncing of data from one system to the next system. So Benefits 24/7 is an enrollment platform, but then that data is migrated to our historic Pay1 system to create eligibility files that go to carriers and to go into the accounting process to create the billing files for an employer and ultimately premiums for individuals who are on self-pay status, or a file that goes to DRS for pension deduction, for example. So data has to migrate from the system that is the outward engagement for both employers, employees, and retirees. And so there are times where the data, and it's not a consistently identified root cause issue that prompts some data to not sync in the syncing process from system A into system B. And so as we get tickets or members contact or retirees contact and things are investigated, there will be a patch that's put in, and it might solve the issue for a dozen or 20 accounts, but it's not solving it for the entirety of various syncing pieces. So we're continuing to kind of work through a variety of different aspects to get the files to sync better. That could, when that data doesn't sync properly, it could manifest as somebody looking like they're dropped. We have the enrollment in the enrollment platform. It's making sure that it migrates into the later systems, and the carriers won't necessarily see something if the data, an enrollment is in Benefits 24/7, but it hasn't migrated properly over into the Pay1 system. So that's kind of the root topic that is always being worked on, and it's the underlying current of the status of the various issues that come up. We have begun a better outreach and engagement with payroll officers. And for example, we're now attending the monthly or the bi-monthly payroll meetings to talk through and understand issues that people are seeing. We've identified a couple of steps forward that we think will help make it a little easier, at least, to see some of the issues. One of the challenges is the background system primarily is a system that the agency uses at this point. We were trying to retire and get out of the having everyone in the state payroll officers need to look at a COBOL system that looks like an Atari game from the 1970s, because it is from the 1970s. But we're looking at opening up some of that view access so that they can start to see some of the potential syncing problems on individual accounts and expedite identifying where accounts are, rather than what is happening currently is sometimes we're learning about the issue because the member goes to seek care. The claim starts to get adjudicated. It's like you don't have coverage because you're not in the file. And then the member goes back to their home agency, and then their home agency contacts HCA. If we open up some of the access to be able to see the background system for payroll officers, they will be able to help us identify those issues on accounts in a more anticipatory way. So we are still working through things. We are aware of a variety of different issues that are coming up. It's unfortunately not a one and done cause solution. And I want to reassure the board that the three things that we are working on with regards to benefits 24/7 are stabilizing. So that includes the syncing issues, the changes necessary to implement UMP Part D transition, and the changes that are necessary for the standalone vision carve out. Other than that, there were a lot of things that people wanted to do, and they are all shelved until those things are done. So Lou, did you want to add something?
Yeah, just had, Kurt, when I'm explaining this to folks, basically I just let them know that unfortunately the system of record is the one that's 40 years old. That is the system of record. That's the one that shows when you have benefits. That's the one that syncs with the carriers. That's the one that does all that. The beautiful front end, that's the one we want people to interact with, but it's those syncing issue to the system of record. And that is the fundamental problem, is that our system of record is old and broken. And we're doing the best we can with it and replacing as we go. So that's kind of the elevator speech on.
And the other thing to highlight is we can't simply just key something into the back end system because the nightly sync file will override it. And so we truly have to solve the sync issue. We could force it in the back system, but it would get overwritten on a frequent basis. So that's the piece that we're really working through.
Okay, no, I appreciate all of that, Lou and Dave. And it sounds like you're already doing it, but part of the frustration was they didn't feel like they were getting any, adequate response from some folks they're reaching out to contact. But it sounds like you've already addressed that, and
we are righting the ship on that in recent
weeks.
Yeah.
Awesome. All right, appreciate it. Thank you.
Thank you.
Other questions for Dave? All right. Oh, hey, Tom.
Yeah, before we start John's presentation, I have a question because one of the correspondences that we received from Jessica referred to questions on supplemental insurance offerings, and they said that they were unaware of these other offerings available through the PEB. Is that what in John's presentation is that what some of those that are being referred to in the letter writer?
Tom, it could be that. Sometimes people refer to the supplemental benefits as the additional coverage one can buy for life insurance beyond the employer paid benefit. And that also it's less used now by people for LTD now that it's an opt-out benefit instead of an opt-in. So sometimes people, and we in fact used to call them supplemental benefits in our rules and our marketing materials. So that language is still not kind of been struck from the psyche of the population as to refer to those benefits that way. So it could refer to life or LTD employee paid benefits. That's the phrase we use now, or it could be referring to auto insurance. But that's generally the answer to your question is yes.
Yeah, because it was just a little vague. I was not quite sure what the writer was referring to.
All right, other questions? All right. John Parton, our Benefits Strategy and Design Section Manager in the PERB Division, is bringing us a presentation today to go over the property casualty insurance benefit and some proposed evaluation criteria for future possible benefits. Materials behind tab number 4. John, welcome.
Thank you very much, Chairman McDermott, members of the board. Thank you. This was introduced by one of my colleagues, Andrea Philhauer, a few weeks ago, about a month ago. And just to refresh folks' memories, as Tom alluded to, this is specific to property casualty accident insurance that's facilitated through a payroll deduction. And there is a specific piece of the revised code which authorizes the board to offer this type of program. It doesn't require the board to offer it, but we do have one legacy plan that's already been approved previously some time ago by the board. That contract is up for review. That's what made us start looking at this again. And one of the other pieces, if we advance to the next slide, it's the actual RCW that covers this. What is required of the board is to have a process for reviewing these plans when they come to be reviewed and evaluated. So that's really what I'm focused on today, is going through what that criteria could look like. And then eventually, next few weeks, the next board meeting or two, we'll bring that back as an actual resolution. And we have a proposed resolution to adopt these criteria. So I'm going to run through those today, seek your input, and there'll be a chance for you to provide some feedback before the next board meeting to anything you think doesn't make sense or you want to see added or deleted, additions, etc. So this is the RCW. There's another one. As I understand it, at that last introductory meeting, there were some questions about scope creep, which is understandable, given what we're talking about here. And you'll see in the criteria that we're suggesting, there's something around that. But there is another RCW, and I've included it in the appendix, which talks about the types of optional benefits that the board has the authority to consider. And that's kind of what would put up the guardrails around what we can do. Now, again, remember, these are things that the board would be reviewing. We'll do that evaluation using these criteria at HCA, but the board would be the one saying, yes, we want to offer this, or no, we don't, or ultimately answering that question of, is this within scope? So I've just provided those for reference. Okay, we'll go to the next slide. So this begins the actual criteria we're suggesting using. And a question?
All right, this may not be appropriate to address this at the moment, but what I noticed is one WAC that you referred to, well, when you referred to 4105.065 subsection 9, that's only for active employees. But then later, when you discuss, I think on page 3, proposed evaluation criteria for contracts under RCW 4105.065, you don't have the subsection 9. Are you expanding it to include retirees? Okay, I was not clear.
Yeah.
And so I just wanted
It's a
clarification.
great clarifying question, yeah. But
Okay,
the
thank
thing that
you.
really
That's
tied
all.
it back for me is that reference to the fact that it's property casualty and accident insurance and done via payroll deduction. But yeah.
But for the uninitiated like myself, I thought, oh, are they intentionally leaving out the subsection to expand this?
We'll clarify that. It's a good call out.
Thank you, sir.
Thank you. Okay, so I've grouped these into a couple of different categories. We'll start with the product differentiation. And these essentially are trying to drive at, is there something about the benefit design that's different than what a member could get going directly to the company outside of this arrangement? There are different sets of benefits, different deductibles, coverages that might be available. Is the product's benefit design and coverage amount competitive, right, with what others are out there in the market that someone could get directly from those companies? We wouldn't want to necessarily offer something that was at a better price, right, but had lower sets of coverage amounts. That's what this is really driving at. We move on to the next slide, some more on product differentiation. Does it offer improved access? And this could be something in terms of the geography that it covers, rural coverages, or it could be something around accessibility. Is the way that the company interacts or accepts applications or interacts with customers, is it done in a way that is more accessible for members who have disabilities. So things that we might want to consider. And then finally, on the product differentiation, is the proposed plan to offer discounts. And that's the case with the current one that we have. There are discounts that are available that if the member did not go through the payroll deduction through HCA, they would not get on the general market. So it's more affordable. Next one, next slide, please. Member convenience. In the process of applying and the underwriting processes, are they streamlined and easily understandable? I don't know how many of you have recently applied for auto insurance, but just going through and figuring out what the right level of coverage is and the umbrella coverage is, the difference between the LDW, the liability insurance, and the umbrella coverages. Is it made clear to someone what they're actually signing up for and what they might need? Can the carrier demonstrate that they're consistently timely and responding to customers or customer requests, adding a spouse, a partner, other dependents to your policy, or changing the policy coverage amounts? Something I used to get all the time, right? A recommendation that my coverage need to be updated from my employer based on how much I was driving for work. And that I would then have to go have that conversation with my insurance coverage. So is that easy and are the responses timely to those types of requests? And then does the carrier offer secure, reliable options for automation of member payments? That's the payroll deduction. You can also do it through electronic fund transfer directly out of your bank account. We want to have some assurance that they're as secure as they can be, right? And that's we'll get into data retention and data privacy in just a moment. So member convenience, that's what's there. We go to the next slide. These are more general questions and criteria we might use. The level of administrative burden, both for the employers to administer this, whether that be a state agency, a higher education institution, et cetera, and the members. Is it not creating additional unnecessary administrative burden? Would it be reasonable to expect that offering this kind of a plan would have some positive impact on agencies or institutions' ability to attract and retain qualified job candidates, and that might be a differentiator for them and for us? And then finally, on this slide, the benefit offered aligns with the benefit offerings under those two RCWs that I mentioned. And thank you again, Elliot, for the call out. We'll clarify that this one specific section of that second 4105-065.
John, I do want to highlight and make sure the board's very clear that RCW 4105-745 currently applies only to the SEP board. So those are benefits that the SEP board has the authority to consolidate. There is for the PEB board to have that authority would require an act of the legislature. And it's something that the agency is looking at the moment, and something that, if there were an idea around that, it would be stakeholder. But that suite of benefits right now, the PEB board doesn't have authority to do. But it is not, it's a fairly simple type of legislative bill to quickly make it applicable to both programs that could represent a future state. That list was carefully curated and negotiated several years ago in a legislative process. And so there's no reason to think that that list wouldn't be the starting point, or starting and possibly end point for the discussion. It's just simply whether to also grant that board that.
Great point, thank you. We advance to the next slide, please. This one, we thought about how to word this, but essentially there are two important pieces here. All right, one is that the carrier is licensed in the state of Washington, and number two is that they're in good standing with the Office of the Insurance Commissioner. And to me, that means that they have no active actions. In effect, there hasn't been a complaint filed, and there hasn't been a finding of that complaint by the OIC investigators or by a member of the community that has coverage through the carrier. So that's the OIC also reviews a number of other aspects for insurance carriers. And these particular kinds of carriers, property and casualty or accident insurance, they do look at financial sustainability and viability. So that would be another important piece, that when we look at, are they licensed? That's part of in the state of Washington. That's part of the review that would give us some assurance that they have substantial enough reserves to be able to function in the state. And then the next one, their marketing and communications, the way that the vendor, the plan communicates with members, is it consistent with the other types of voluntary or optional benefits that we offer? As Dave mentioned, the long-term disability being an example, and that it's clear that it's a voluntary or optional benefit, and we're not unnecessarily guiding people to think that there's an endorsement of the plan or anything like that, but it's completely optional and the member is paying for the coverage. And then finally, can the vendor show that it will comply with any and all relevant data retention and data privacy policies, whether they be federal, from the state, or from the healthcare authority itself, all of which have some form of data privacy and retention requirements. We flip to the next slide. This is the actual proposed resolution, and essentially this were there any questions on the criteria though as we went through them?
Yeah, I have go back to referring back to page 4. I want to talk about the first bullet just a bit, and maybe talking about 6.1, half dozen of the other, but it talks about improved access. I want to see if maybe there's some discussion to flip that, not improved access, but make sure that it's equitable access. Here we're saying more improved access for rural, and my concern is that forward thinking would be that it doesn't exclude that group inadvertently or unintentionally, if that makes sense. I just throw that out there for consideration. Maybe just splitting hairs, maybe saying the same thing just differently. And the other thing is on the second bullet there, does the plan offer discounts? I think that's the way it might be. I don't know if that's the way it's stated in the RCW, but I'm wondering if maybe pricing might be a better word, or there's some other word rather than discounts, because there goes more into evaluating something about what kind of discount do I get. I mean, you're going to give me a discount on $1,000 policy. Maybe you're better off getting an $800 policy, and get the same thing as opposed to a discount. So that's just a couple of feedback thoughts I have.
Yeah, I appreciate both of those, Harry. And on the second point, this is a difficult one. It's a slippery slope, right? Because these are individually underwritten policies. So the question I think you're really driving at is the member getting a better deal than they could if they went to a different carrier in the public? And in an individually underwritten policy, I'm not sure that we're ever going to completely be able to say, yes, this is the better deal for you. Member's going to have to shop that. But what we can say in this case is that there is that additional discount that's only available when it's set up through a payroll deduction. And that's pretty substantially different than what is available to others. Now, again, it's going to be a discount applied to an individually underwritten premium. So members still going to have some responsibility to shop for that. But I hear your concern. So it's something we'll think about, see if we can come up with better language
It's
for
not
it.
a big deal.
No, it's a good call out. Appreciate the input. Elliot.
Harry made me think perhaps we're talking about value, but again, that's relative in the eye of the beholder. I think discount is a better word than pricing. I get confused by the word pricing. Pricing in terms of whose perspective. And it takes in a lot of territory. It's a very vague term. I like discount because I think what I always think about is whenever I used to write laws and stuff, think about whether my audience is 7th grade, has a 7th grade education or 8th grade. Discount to me might be more reasonable to them, more concrete. Value again is part of the expression, a squishy term. So personally, I think that's okay, but I see the problem that you're trying to address.
It's kind of like when we talk about healthcare literacy, right? Is you want the member to understand that discount is great to have it, but you need to still shop for, is that the most effective premium, the cost effective premium to lose it? I think you made the point earlier about, am I getting the best value for the premium that I'm paying? It might have been Harry who commented about the coverage amounts. So yeah, we'll give that a little more thought.
Sometimes I found when I wrote a WAC, if I gave an example, it kind of helped people. It's just a thought.
Okay. Any other thoughts or questions? Reactions to the criteria?
There might be more questions after you go
Yeah.
through the resolution. And yeah, I'd suggest going through the resolution, then we'll do another call for questions.
Okay. So if we go to that slide that shows the proposed resolution, please. There we go. So this essentially has two parts. The first would be rescinding any prior board actions or decisions, resolutions related to the provision of property, casualty, and accident insurance plans. As I said, this was done, I think it was mentioned in the prior presentation on this. The one contract we currently have here is over 20 years old. And so a lot of what was done by the board at that time and the criteria that were even used to evaluate that proposal, some of that is lost to us. We can't rebuild that at this point. So whatever had been done previously, we rescind, and then we replace it with these new evaluation criteria, and that the board would adopt those as presented today with any additional feedback and changes that we might make, revisions that we might make by the next board meeting. In evaluating contracts offered under, and we'll again add that subsection of RCW 4105/65, subsection 9.
And the structure of this resolution really follows a pattern that we've used in recent years, where, we do our due diligence to best we can to go through historical documents, and we have a fairly, things that are older than 7 years don't have to be retained by state agencies. We retain a fair amount of board information, but still, there is a point where it is not easily identified or found, and we just don't want someday somebody to come forward and say, oh, I have a copy of that presentation from 1992, and here's what the board did, and this is very clear. Like, whatever was taken, even though we might not have a perfect awareness of it today, if it gets unearthed at some point in the future, it's rescinded. And we've done that. I think this will be the third instance where the board's been brought something that starts with that general rescission of potentially unknown information and just kind of rebooting, if you will. And then we've also taken this approach of, rather than have a resolution that goes on for 5 or 6 pages, we say, see the presentation on a specific date. And so if there are refinements that we'll take back the feedback and any other feedback when we do another call for questions right now, if there are refinements, then you could see the date change on this, because we might bring forward another presentation in 2 weeks that says, here's a slightly different version. The one you're adopting is the one that was presented on Y date instead of June 13th. So
Could I please ask that under the proposed resolution, whatever version you have, you add subsection 9? Thank you.
One comment, and this is just me, I would love to see something juxtaposed for older people. I don't have to be for the entire board, but for me to see the 20-year-old piece of what is obtained from that for this new piece will be very helpful to me to understand how we're moving forward. I just hear rescinding, and I don't know what's being rescinded and why. And so that, certainly not for everyone else on the board, but for me to see.
if we had it, Sharon, it would be in the presentation. We have come up with this language, this approach where when we look through our historical documents, if we can't find a specific action or a slide or a resolution, we're not going to assume that there wasn't something. We just don't see it in our records. If there was something that was available to show you that was rescinding, we would include that. So we don't have something that we've identified. It was roughly 1998, 1999 when the board would have taken action, given the execution date of the contract. And so we have not identified something that specifically needs to be rescinded. We just do this out of caution in case somebody someday unearths it or finds it, or somebody's bringing some sort of challenge, just trying to kind of nip it in the bud to be very clear that even if we're not sure what was done in the past, and we're not even confident that there actually was criteria set by the board 23 years ago, it's a reboot. So normally if we had something to rescind, you would have that in your materials. The fact that we don't have it in the materials, we haven't identified something specific that you're rescinding.
That's why it's really weird to hear the word rescind.
Yes.
You know,
Yes.
there's nothing to rescind, we don't really have something
Yeah.
concrete, but that was my question.
And if we go to the next slide, the next steps, we'll incorporate some of the feedback we've heard today. Think about some of the feedback we've heard today. Any other feedback that you have, you could please submit it to the email address that's shown there before the 20th so that we can prepare for the next board meeting. And if we need to, whatever we need to bring back, whether it's the policy resolution for action or some revision to walk through, we'll have that prepared for the June 27th board meeting. And as always, you can feel free to reach out to me directly. My contact information is on the questions page, and then I've included what else we have in the appendix just for your awareness.
Any other questions for John?
Yes, I do. So you mentioned that you're in the process of reviewing Liberty Mutual. After we've been 23 years, my assumption is number one, that this criteria will be in a resolution prior to that review being concluded. I understand that. The second thing is, well, how do we keep out of the procurement business here? Because there are other carriers who might be interested in offering this. You're not going out solicitation, I don't think, but you know, so how do others? How do we not have others say, well, you sure would be nice if you let me know, or do we even need to be concerned? I don't think we need to be concerned about that because it's always been there. But would this not be an opportunity for, at any point, for another vendor that offers this kind of product to come forward and say, I'd like to offer it also? I mean, we don't give exclusive to one, correct?
Generally speaking, we don't. And I wouldn't say that it's never happened, right, that we've chosen one. But I can tell you that my team takes so many vendor calls on a daily basis from vendors shopping for, would the state be willing to do business? Some of them do have to go through procurement, some of them don't because of the relationship with an existing payer partner that might exist. So that's something that we have to weed through in the individual inquiries. But there's nothing that prevents the marketing reps from approaching us and talking to us. And we generally take those calls just to see what kinds of things are out there. It might not lead to something with that specific vendor, but it might germinate an idea for my team about something we could offer, we might want to explore. But I would expect that's kind of what they get paid to do, right? To generate the business, and they can approach
John,
us.
if I was a sales rep from ABC insurance company that offered auto casualty, this kind of insurances, and I called in, hey, I want to talk to John Park, you got on the phone. Hey, I understand Liberty Mutual offers discounts. We'd like to come in and talk to you, see if can we get in on the program. Is that the kind of thing you say, well, don't bother, we already got somebody, or is it, you know, I mean, it's kind of a, you know, icy, uncomfortable place to be, I would think. I don't want you to be in it.
I'll jump in a little bit on this. This one's a little bit unique because the statute itself says that there shall be review of these specific types of plans. And so if John got that call, that has to be taken in a different route than someone who's calling about pet insurance, which that's not in the statute that has a shall review a proposal that's essentially initiated by the carrier or the insurance entity. On the other type, I mean, most of John's calls aren't about this property and casualty. They're about everything else that could possibly be sold in the insurance market. And those, there is not a sort of, there's more permission to look at things, and many of those things might ultimately require a procurement. This one is just a little unique. If ABC Auto Insurance Company called, there's a slightly different obligation to look at that in a different way than his other calls.
I remember at the beginning, typically in the board retreats, we go over that benefit planning cycle, the circular motion set of slides. That's where a lot of those kinds of things go and potentially germinate, right? Create an idea and germinate it, iterate upon it. This is, as Dave said, something a little
For
different.
me, this has been sitting out here for 23 years waiting for this day to happen. And it finally has, so I just, you know, hopefully there's no unintended consequences. I think it's a good move, don't get me wrong, fully supportive of it. Just don't want to see your world get, you know, changed way you don't want it to be changed.
Okay, thanks. I appreciate that. Thank you.
Other questions for John? All right, John, thank you.
Thank you all.
Next up, we have Jenny, the Senior Account Manager, and Ryan, Assistant Chief Pharmacy Officer in the Clinical Quality and Care Transformation Division. We're going to dive into some more details on the PEB program pharmacy administration that will hopefully answer any questions from earlier this board season. Put her behind tab number 4. Jenny and Ryan, hey.
Good morning. I am back. I thought of a fun game. My blood pressure right now versus tomorrow, knowing it's my day off and the presentation behind me.
My new game is called Name That Drug in 3 notes because of all the jingles that we all know. See if we can have a game show that we can guess that drug based on the commercial jingle.
Those fun commercials.
Elliot?
Maybe I can help with your blood pressure. I think Dave knows what I'm going to say. Sometimes there's a presentation that's written in such a way that it is as beautiful as a painting or a fine novel. There's not an extra word. Everything is precise, and it's a pleasure to read. That's how your presentation affects.
Okay.
Blood pressure
I do feel better. I do. I'm going to give some of the credit. Jessica Hagstrom is a great editor of slides. So
Let's do it justice, no pressure.
yeah. Okay. So good morning, Chair McDermott, members of the board. I'm Jenny Switzer. I'm a senior UMP pharmacy account manager in the PERB division, Employees Retiree Benefits division at HCA. And today, Ryan Castresi and I are going to go over some information about pharmacy administration. I'll go over the UMP pharmacy and how that program really, all our different programs come together, as well as some information about PBMs, pharmacy benefit managers, and then we'll transition over to Ryan, giving you some great detail about rebates and other information on our programs. So on the first slide here, again, going over benefits organizational structure. Next slide. This is a quick little graphic, not really telling you very much, but this is really the whole of our UMP pharmacy benefits. So today I'm going to go over ArrayRx, what that is, what role they play in our program, as well as the Uniform Medical Plan. That's who we are. ArrayRx directs some of our contract language and how we offer our benefits to our members in the state of Washington. And then also information about MODA and their role in the work that we do with them. The next slide, again, is just another little visual representation, because when you put it all on one slide, it's a bit heavy. MODA contracts with Arden. I'll give a little bit more information today about what Arden Health is for our specialty medications. They also contract with Novitas, who is their pharmacy benefits administrator. Again, more information coming on that. Novitas contracts with Postal Prescription Services and Costco mail order for our mail order services that are in network with UMP. And they also contract with our retail pharmacies to make sure that we have a rich pharmacy network for our members. On the next slide here, so I thought that this would be a helpful little graphic to kind of outline the Northwest Prescription Drug Program, how it started and where it's come over the years. So in 2001, Governor Locke organized a work group for the Prescription Drug Project, is what it was called at the time, to explore options for prescription drug cost containment. Even back to 2001, we could easily see, or they could easily see, that the cost of drugs was going to increase exponentially, and that would be a huge impact to citizens in the United States. In Washington State, let's focus a little smaller on Washington State there. And so that work group was put together, and 10 state agencies participated in that work group. A couple of years later, in 2003, the legislature instructed HCA, based on information from that work group, to make a way for agencies to purchase drugs to control costs. And that solution became known as the Washington Prescription Drug Program. move forward a couple more years, and the legislature expanded the prescription drug program mission by authorizing us to adopt policies to help us establish a prescription drug purchasing consortium. And then the next year, Washington and Oregon, because Oregon also had legislative rules written in about the ability to enter into a consortium agreement. Washington and Oregon established the Northwest Prescription Drug Consortium, which allowed Washington and Oregon the ability to pool their purchasing power to purchase drugs at a lower cost to help keep premiums down for members. Jump forward to 2022, the Northwest Prescription Drug Consortium. And so in previous board meetings and in a lot of communications, you've probably just seen it written out as the consortium. So the consortium changed its name to ArrayRx. This allows branding across the states to go back to one name of the program, where it's for continuity of understanding. Yes.
I would just say also it's for helping potentially add other states into the consortium. It's rather confusing to people if you're, in Nevada, for example, and you're joining the Northwest Prescription Drug Program. It just is a little less intuitive to people. And you will see that over the years, there's been a little bit more expansion into other states that are not in the geographic Northwest because the name was kind of limiting to people's concept of potentially joining. Elliot?
This is not a comment about your presentation. It's about my lack of education. Array is it the administrator? It is not, correct? It is.
I'm gonna go into, we do have some slides coming
Yeah,
up where
I'm so.
it's not just you.
It's not.
That's why I'm
It's
here
not
today.
about presentation. It's what's a PBM? What's an administrator? What's a?
Yeah, we'll go, not to, sidestep your question, but I'm gonna go into that in more detail and you'll probably have more questions based on that. But let's jump forward to the next slide. This is just a visual representation again of the timeline from 2003 to 2005. The only options available through that the Oregon and Washington Northwest Prescription Drug Consortium was a discount card that allowed people that didn't have drug coverage to purchase drugs at a little bit of a discount, or maybe you have drug coverage, but you're purchasing a drug that's not approved or not covered under your plan. That card allows a discount. And then 2006 to 2021, a lot of services have been added to what ArrayRx offers. Again, we'll go more in detail into ArrayRx. For the UMP population, we use the pharmacy benefit management services, and we use the discount card program. But there are multiple services that are available for different groups. Like Dave mentioned, different groups, different states can opt into participating in ArrayRx, which, since part of the one big part of the mission is to use our purchasing power to drag down those costs of drugs, can be beneficial. So I'm going to focus on UMP today, so don't ask me too many questions about Medicaid. I have to tap in, my friend, right over.
Sorry, everyone. We had a couple of technical difficulties in getting right back in, so we're going to pick right back where we left off. Jenny.
Again, yay for our admin team. We're quick on that. The next slide. So here we go. Let's jump in a little bit into ArrayRx and what they do. So as I talked about before, there's an RCW that states that state purchased healthcare programs must purchase prescription drugs through the Prescription Drug Consortium, now known as ArrayRx, for drugs that are purchased directly by the state. Washington and Oregon, way back in the day when this first, and this initiative and this RCW was first put in place, Washington and Oregon selected Moda Health after a competitive procurement process. They were then known as ODS Health Plan as the successful bidder for the initial agreement. Since then, ArrayRx has gone out for public procurement 4 times, and Moda Health has been selected as a successful bidder each time. ArrayRx is governed by a steering committee, and each steering committee member has a vote when making decisions on how the program works. And ArrayRx focuses on delivering program transparency and providing complete pass-through on discounts and rebates received.
Structurally, the other thing I'll add about ArrayRx is so ArrayRx is a program that pools purchasing for multiple states, but the primary administrative work for the entire consortium is HCA employees. So when Washington and Oregon created the consortium, the state of Washington took on the primary responsibility of leading the administrative work. So when Jenny says that ArrayRx has gone out for procurement, that's the healthcare authority through that program at our agency administering a procurement on behalf of the consortium. And so we're doing a lot of the administrative work. There is a steering committee that involves the other partner consortium members, but the primary administrative engine for ArrayRx is HCA. And that's a way to remind people of, when you think about the healthcare authority and its current modern iteration, you think of Medicaid, you think of the Division of Behavioral Health, you think of PEB and SEP. There are multiple other programs run at this agency, including the Health Clinical Technology Health Clinical Care Technology Committee, HDCC. We have the Universal Healthcare Commission. We have where the launch of Apple next week. There is a launch for an expansion, a state version expansion of Apple Health for undocumented individuals. There are a variety of programs, and one of them is ArrayRx. So there are other aspects of this agency besides the 4 large programs that people think of traditionally with this agency. Elliot, did I just read 7 questions?
Okay, I guess. So Array goes out and purchases.
They do a procurement
Yeah.
and identified a general Moda Health as the successful bidder, as the administrator. And then all the consortium partners, and ArrayRx creates a core contract agreement that then all of the participating states build off of.
Yeah, so I guess we could have done this in a picture too, but ArrayRx has the master contract, right? So that's the consortium, multiple states, they have this contract, Moda Health. In the state of Washington, any state purchased drug program has to use ArrayRx. There's other contingencies in there, but so they need to use ArrayRx for their prescription drug purchasing because it is the lowest cost way to purchase drugs. Underneath that master contract, so like workers' comp through L&I, they have an agreement, they have a participating program agreement where they have, we'll call it like a subcontract under that master agreement that's specific for their population of people in what they need. So ArrayRx creates master participating program agreement, right? They have a master copy of it. We received that on our UMP team, and it's updated annually. We receive a copy of that master participating program agreement or subcontract, whatever you want to call it. And we go through a negotiation process with MODA to make sure that that agreement matches our specific needs in UMP, right? Because we have a custom drug list and all these things. So we have, this participating program agreement under the master contract. So that master contract really locks in some rates and fees and some expectations for the vendors that possibly we wouldn't be able to do on our own, just as UMP if we went out for our own agreement, because we do have not just the purchasing power, but we have the power of all these different groups underneath it, where ArrayRx gets to say, we don't like that rate that you proposed. We're bringing this many clients, hundreds of thousands of members between the states in. They can negotiate at a better level than we can. So although we get to
customize
and negotiate our specific terms for UMP, those rates and the discounts and those type of things are really set by ArrayRx because they have that ability to negotiate at, you know, I don't want to say a stronger level but a higher level than we would be able to on our own. So it's not just about keeping the cost of drugs down. There's a lot of different components and requirements that maybe we couldn't get on our own because of that big agreement. Does that help?
It's a little, but then I'm confused. So MODA steps in and they just administer it.
They have to meet the requirements as outlined in the agreement, which for them, they have to meet the agreement, the ArrayRx master agreement, and they, and ArrayRx and that steering committee are responsible for that contract management. And then they have to also meet our specific requirements as outlined in our participating program agreement. That means that they're managing their subcontractors appropriately, that they're meeting, you know, timeliness expectations, they're meeting performance guarantees that we do negotiate for UMP separately than the master agreement, based on the needs of our population. What we know is most important to our members, right? So wait times, speed of delivery on prior authorizations, things like that. So yeah, MODA comes in, they administer the benefits either through themselves, and we'll look at what MODA does and what Novitas does in future slides today. But yeah, MODA is that group that comes in and offers these services.
Thank you.
Yeah. All right, so this next slide, the benefits of ArrayRx. So like I've talked about, a larger pool of members to negotiate rates, right? We just discussed that. Aggregate group of members to reach lower fee thresholds, and group claims volume to reach lower fee thresholds. So that's that group purchasing power that I talked about under ArrayRx, because there's so many members involved in that consortium. I'm going to go back to the word consortium. They have those benefits where they can negotiate at a better rate. And then this also saves us on the UMP time because we don't have to go out for those requests for proposals, which if anybody's ever been involved in that process, it's lengthy and time consuming. It's a lot of fun to read through hundreds of pages from different vendors that are putting in. We don't have to, not on UMP, we don't have to go through that RFP process. The ArrayRx steering committee does that for us. But they do take into consideration the needs of the different participating programs. And so they take our state interests and they prioritize those. So when they're writing that RFP, these are what our members in the state of Washington need. These are the laws about coverage of insulins and things like that. And so they do take our interests as a top priority when they're negotiating or looking at RFPs. They offer the contract services. Like I said, they're responsible for oversight of that master agreement. And there are times that even though we have a subcontract or a participating program agreement, there are times that we have to go to ArrayRx and say, hey, we're trying to understand the terms of this contract space. What is your take on it? Can you guys go to MODA at that higher level and have discussions with them? Because we would like to make a change to this, or we would like this to be covered in a different way. And then, like I talked about, they have a contract template, which also saves us time and money at the UMP level to just get that template and then update it for our specific needs. So I'm going to pause there because those are the slides for ArrayRx. We're going to move into MODA and Novitas and all of that. Any other questions about ArrayRx? I know it's kind of, that meme of that guy like doing math problems on a whiteboard. His mind's just going crazy. It can get like that at times, but okay. We can always come back to questions too. So on the next slide, this more goes into, Elliot, like your question, the MODA Novitas services that they provide. So as the contractor for our participating program agreement, MODA provides account support. So that's their account team. You guys have met like Kristen Cisaroth before has come up and spoke. She's, kind of the leader of our account team that we work with. They provide plan descriptions, they attend benefit fairs and provide materials for open enrollment support. So if you go to a benefit fair to hear about what benefits are available to you, if it's an HCA sponsored event, you will always find a table with our actual account team members. They don't just send, somebody that from the call center that's maybe really heard of UMP. Our actual account team members that we work with every single day attend those benefit fairs. And they provide oversight of the Arden and Novitas contracts. They offer clinical services. I talked about that preferred drug list. And so they provide recommendations. Their clinicians will go in and then they're watching to see what drugs are coming to market, what changes are taking place in the realm of generics and biosimilars. And so they'll bring us recommendations. MODA manages the prior authorization process. So if you have to submit a prior authorization, that's MODA that's actually looking at those and reviewing them. They do utilization management, they do clinical reviews, they manage the appeals for UMP. Under benefit design, they look at, the eligibility for different drugs. They administer the benefits for us, right? And they invoice us for the fees associated. We don't pay Novitas, that's a subcontractor. We don't pay RARX because that's, part of our state program. MODA invoices us for the claims costs. We'll go more into some fee structures later. Surrounding PBMs, but they also provide member services like the call center. They provide communications to members. So if there's a negative change, your drug is no longer covered because data has shown that it's not medically efficacious, or maybe the drug interactions are such a negative health risk that we're going to have to switch you to a different generic. MODA would be the ones that send those communications for us in addition to many other communications. They have a member portal that you can log into and look at your benefits, and they do the direct member reimbursement. What that is, so Novitas manages the electronic claims that go through the pharmacy systems. Direct member reimbursements are you go to a pharmacy and forget to use your ID card, you pay out of pocket for your drugs, and you have to submit a form to get reimbursed at the network rate. They also provide reporting and analytics, which Ryan and his team, Ryan and Luke, love the analytics portals. They provide some actuarial services and plan modeling. And then we get down to Novitas, who is our pharmacy benefit manager. And they, like I said, they do that claims processing. They manage the pharmacy network, as I mentioned before. So they negotiate contracts with pharmacies to make sure that we have that large network of pharmacies available for members. They also have a reporting portal, so it's a little bit different level of information than the reporting portal that MODA provides, because Novitas actually does the claims administration. And all of those reporting portals, just in case it piques anybody's interest when we talk about claims and reporting portal, it's very, like I don't have access to claims information and stuff. So that concern that sometimes people have where, oh, everybody at HCA is looking at all my claims information. We are very, very cautious with who actually has access to that. It's exceptionally limited. And Novitas also provides our rebate management. Ryan's going to go into rebates later on, so don't ask me too many questions because Ryan's worked really hard on his presentations and has a lot of great information to share with you. So there's two of them. MODA has a reporting portal where we can look at things like something I used it for a lot in the last couple of years. How many claims are going through for COVID test kits, right? And so I would just get not the member level, but I can see how many COVID test kits were processed, how much that cost the plan, not the member because there's not a cost share for the member. And so that's the member reporting portal. Novitas has a reporting portal that's more claims based. So we can see the actual cost of all of the claims. So if we have like a high cost drug that we're trying to track and make sure and watch the cost on it, because we want to make sure that we are containing that in case we need to go back to MODA and say, can you guys look at what we're paying for this drug? Because it seems like we're seeing a lot of this drug being utilized. That's where the Novitas claims reporting portal comes in.
Then you have access to that reporting portal, right? I mean, you have to go say.
I have limited access. I cannot see member-specific data, but I can get an aggregate.
Yeah.
Yes.
So this is Brian, Mr. Essie. So as a clinician, I get to access the claim level data because some of my work here at HCA is to resolve appeals and other case management stuff. So we do have very restricted access for that claims data, and I think it's limited to just the clinicians here at HCA for work on those types of issues.
Yes, very limited. So if I need, if we have a member that reaches out and has questions about a claim, I either have to go to MODA or reach out to Ryan to say, hey, can
Right,
you look
I
at this?
understand the HIP implication
Yeah.
and all that other stuff, but so what my point was that you don't have, for aggregate kind of reporting, you just, if Dave came and said, hey, can you give me an idea on certain medication? You don't have to call down to MODA, who calls down to Navitas.
Yeah.
You can directly access it.
Yes, yeah. And it's a pretty small list of people that even have, you know, that high level access like I have. We don't really expand it beyond because people don't need it. In the next slide, we will look more specifically at Novitas. So that was probably 3 or 4 bullets right on the previous slide. So some other things that Novitas does, they contract with Postal Prescription Services and Costco for our mail order network services. They provide after hours pharmacy and member customer service. So if you call at 10 a.m. on a Tuesday, you're going to hit the MODA customer service help desk. If you call after hours late in the evening, you're going to hit Novitas. They provide that support. They do the negotiations for drug purchasing agreements. So those manufacturer agreements where we get to use our purchasing power, Novitas does that on behalf of the program. So they can go in and say, you know, hey, we've got this many people, what's the best deal you can give us on these drugs that are needed for members. And then they also host the platform where the online price check tool and the pharmacy locator tool are, because they're the ones that contract with the pharmacy. So it makes sense that they would host that, but that is, you can access that directly from the MODA member portal. It's just hosted by Novitas, as they have that access and can update it daily if a pharmacy leaves the network or joins the network. All right, next slide. So in prior board meetings this year, I've gone over pretty in depth about Arden Health, which is our specialty pharmacy, but I wanted to touch on it real quick just to give a refresher. Arden is contracted with MODA Health, and they provide specialty drugs that are generally high cost, high complexity, high touch. You have to have a lot of patient education around how to store or administer these drugs. A lot of times they treat rare or very complex conditions, so members need more information. An interesting thing, just a couple weeks ago, we actually went to the Arden facility, a group of our UMP account team to meet with some of their employees and to see how that works. And they actually provide the patient education over the phone when they connect with members about, okay, you've been prescribed this drug, here are side effects to watch for, here's how you should be feeling a week, 2 weeks into taking it. But they also, inside the box, when they ship you your medication, they include helpful tips and information, how to manage side effects, that, you know, if you're experiencing this, maybe a ginger candy can help, or these type of things. So it was really interesting to see at the high level how much they prioritize member outcomes and care.
Quick question, they're not a PBM?
Arden?
No.
No.
What?
Novitas is our pharmacy benefit manager. Arden Health provides just specialty medications, and they're contracted to provide that for our members.
See, the models that I've been researching on the web, or it's like you have an administrator, you have a PBM. The PBM does all this stuff with the manufacturer, and then it goes to the administrator, and that's it. I'm not criticizing this, but that's why I need your help. So Arden is another subcontractor of some kind.
Yes.
Yeah, so this is Ryan. So Arden is a pharmacy, right? So if you think about a pharmacy that you could go to out in the community, this is, where Arden is in that chain. But they are a specialty pharmacy, so they only distribute and dispense specialty medications. And so these are very high cost, high complexity medications that need special shipping, special handling. They, have very high side effects. And so this is a pharmacy that is specifically to one service for our UMP members. Since pharmacy, especially pharmacy, is a small percentage of our entire drug utilization, we can contract with just one specialty pharmacy to serve all of our members, whether they're living here in Washington or around the country if they're in a community. So this, and if you think about that kind of complex web that you were looking at, Arden here is at the end where they're a pharmacy and they're the ones directly interacting with our members.
Thank you so much.
Yeah, thanks for taking that to an understandable level. They're a pharmacy. That was great. Thank you.
Thank you
Sure.
so much for that clarification. Really, this is quite impressive what it is that they do. Is there an interface between them and the public? And what I mean by that is introducing the public to patients who will normally use their services, for instance, cancer patients, whatever, to these folks, letting them understand ahead of time that because that service is highly helpful. I think that interface may be really important for folks.
Sorry, I can't hear the speaker.
We're good at projecting. So my question was, I love the services they provide, very impactful, especially for the kind of populations that you're talking about. Whether or not there may be an interface between them and the public. And when I say by an interface, is that introducing them, whether it's a healthcare provider or whatever, talk to the patient that this is this group, this is what they provide for you, to kind of usher them in, to assure that they're able to access and know that this is available for the services that they will need, is my question. If that makes sense.
Yes, yeah. So Arden does do an outreach. So whenever a provider is going to prescribe one of these specialty medications to a UMP member, that prescription will go to Arden, and Arden will do an outreach, to that member to establish some of that information to understand, we got this prescription for you. What did your doctor tell you about it? What can we inform you about it? Information about expected side effects, when it can be shipped out. Right, because you want to make sure that these medications are there when you're home, or if they can be shipped to your office. If you're working, 9 to 5, and you can't necessarily go home to get it in the mail, they can ship it to an office. So they do a very high level, touch at the very beginning, and over time they do continue to check in with the members to make sure that the medication is working, that they're not having these unintended side effects. And if they are having these unintended side effects, what are management strategies to deal with them? So they do have a lot more communication than a typical pharmacy because, as you know, these medications do have those types of effects on people.
So then what I'm hearing from you is that once the patient has been identified as a patient of substantial need by the provider, Arden kicks in right away. The provider does not have to do that initial interfacing with the patient.
Right.
Very good thing.
And I can speak to like personal experience. I was using a specialty medication with my last pregnancy to keep me from going into early labor. And so it was an injectable. And Arden called me like the same day that I saw the doctor. And they were like, we got a prescription here, let's talk about what your needs are. And it was and my doctor did mention, this is going to be from a specialty pharmacy and they're going to mail you the medication. And they called me really quick. And then they checked in with me, I think a couple weeks after my initial dose. And then every month they called me to see how things were going. So my experience was a really good one. And that's kind of what they pride themselves on. They talked a lot about that during our tour of the Arden facility, was how often they check in with members. And if a member indicates, yeah, I have a rash, they will check in with them much more often. They'll put a call reminder in for the next day or a couple days after they say, well, have you tried, using a cold pack or something like that? They'll check back in with them to make sure that they're seeing improvements in those side effects, or to even talk to them and connect with the provider to say, hey, maybe this is a drug that, you know, you're having some severe side effects. This is a different drug that you may be interested in. They'll actually connect with the prescribing provider too, to help recommend different drugs.
And I know,
Sorry, just, this is a very basic question, but I imagine they have that interpreter services as well, given the diversity of the population, so immigrants, populations, whatever.
Yeah, that's a requirement in our contracts with MODA, is that they provide interpreter services.
and I know folks are thinking, wow, that's really good concierge services, you know, reaching out and doing. It's because these drugs are so expensive. They're so expensive that if somebody takes one, starts having side effects, and then just is like, I'm not gonna take the rest, that's a lot of money. And so it is in everyone's best interest to work directly with the client to make sure that the medication's working for them. And if it's not, identify the alternatives as quick as possible so that there's just not all this money on the table driving prices up. So there is a lot of touch that goes on with that.
Yeah, and Lou, I was gonna add to that, the data point I always remember is it's roughly less than half of 1% of our drug prescriptions, but it's over 50% of our drug spend. And that's why the service, the concierge high-end service is so important, because it is driving the majority of drug spend, even though it's a very small part of the actual overall drug utilization of the plan.
What Sharon's question helped me think of is the questions I get from my members are, UMP has a secret list of the preferred drugs and this whole system that you've been explaining. And Elliot, you have it. Give it up. And I tell them I don't have a clue. There's kind of this assumption, and I'm sorry, but that you and I have the secrets to the UMP kingdom, and that this whole structure that you're explaining to us, they have no idea what it is, and they're suspicious. I can't say it any other way. And I think the more light we shed on it, it might be helpful to reduce that suspicion.
Yeah. I think there's always suspicion around healthcare, you know, like there's a lot going on in the news all the time about healthcare, and we are a state agency, which some people are like, oh, the government. But we do have a preferred drug. We're not Starbucks. We don't have a secret menu of things. The preferred drug list is updated monthly, and it includes all the drugs that are included, that are covered under our benefit. And it includes whether they're covered in tier 1, tier 2, if they're a specialty medication, it includes whether you need a prior authorization for that drug. We do try our hardest to get, you know, information out there to members. We put smart health activities out. We send notifications directly to members when there's something that specifically affects them. Open enrollment materials. All of those include information about heart and health, and especially how to use the preferred drug list. And because of this board, a few board meetings ago, talking a lot about the price check tool and how people aren't aware of that, this year you're going to see a lot of information. We've added a lot of content to the open enrollment materials and the COCs. And so that's another place where you can go and search for a specific drug and see if it's covered or not.
Can you send a link to the, can you make sure the board gets a link to those, to the PDL and cost tool and all that?
Yep.
And one other resource that I would mention is that MODA's customer service line is happy to help. So in case that people, you know, aren't sure of whether a drug is covered or not, you know, they may look at that PDL and they may have trouble finding that because it is listed by drugs, you know, drugs are hard to spell, you know, it's grouped by drug class, which may not be intuitive to some people. So you can always call MODA customer service and ask those questions, and they'd have someone that would be more than happy to help clarify and explain exactly, you know, what is going on.
That's the most frequent question I get, and I'm assuming that's on the HCA website somewhere.
Just send the telephone number along.
Just underlying Lou's question, Jenny's statements, and Ryan's statements is something that I think most people at HCA know, but it just hasn't been said. Preferred drug list is online.
Yeah.
Yeah.
Anyone can access the preferred drug list for UMP. You can
Yes.
also call MODA because it might not be intuitive as based on the organizational
Exactly.
structure, but there is literally a PDF document that is updated every month that anyone in the public in the entire world could click on and see the preferred drug list.
Could you, at the risk of being very basic, could you send me the link? And then I think if some of our client, I guess I'm calling them clients, they're really not
Members.
volunteer members, I'm sorry. Going back to my old days. Yeah, so we could send them the links. It's right there, folks.
And every single communication that we have that talks about pharmacy benefits has the customer service phone number for MODA on it. Right, every single one.
Yeah, and that would be great
So.
to have as well, the link and the phone number.
And you can even request a printed PBL, but they're updated monthly, so I would recommend that one. Yes.
This is a loaded question.
Uh-oh.
Solve it here. But the information overload is daunting for people. And so I think someone mentioned health literacy here. It's not just health literacy, it's just navigating multiple links and multiple pages to figure out, okay, is this warranted for me? Is this something that I should be seeing? And I don't know how we're gonna solve that in terms of getting information to people in a way that's digestible and accessible. But I know that people are feeling really overwhelmed and there's so much good information out there, guys, but people are not accessing it for whatever reason. And I don't have any solutions for that, but I know something that has to be addressed at some point.
Yeah, information overload in our society is
It's a
the
real
modern
thing.
problem. It's not just healthcare, it's everything. And I know none of us, I'm sure none of us have looked at something outside of, in or outside of healthcare and been like, oh, I guess I did receive that. I didn't realize what I was looking at. That information overload is, you're right, it is a real problem that exists across kind of all aspects of society, and the more complicated the area is, whether it's finances, health, whatever the topic is, information overload is a real problem, and trying to root out what is the key information and what's key to you might not be key to me. But I know our central communications team is really committed to what was called ROT, like, I forget what ROT stands for, but like going through and eliminating information that no longer needs to be relevant, it's become stale, it needs to be revamped, those types of things. And so that it's a real strategy, but it is a real problem.
And forgive me, Dave, for all this, but we know that it's pervasive, sure, across society, but for health, it's much more important. And to be more streamlined, right? Because we're talking about people's health and well-being and find a way. And again, I know I'm just talking in the air here because it's not like no one's thought about this, but this is certainly something for figure out that resources are there, they're not able to access it because they can't figure out how best to get there.
Well, I think one of the issues they're having is that specialty drugs, fascinating, tons of stuff there. Educating yourself on specialty drugs when you don't need one is a waste of time. For most people, they're not gonna do it. So the trick is, how do we put the information out there so when it comes time and you need it, there's a way to get to it. And that's why the newsletters are doing things, but unfortunately the newsletters same way. If you're healthy and things are going well, you see the newsletter, you sort of skip through it and you're like, eh. And so having a place to call, having people that can answer questions, having a website that is accessible, granted that there's some navigation issues that people have trying to find things, but it is always a work in progress, because the worst thing is when you're going through a health crisis, now you're like, now I need to educate myself on all this stuff, and how am I gonna do it quickly?
And another thing I wanted to mention is that your local pharmacy is another resource, right? So even though we have a lot of information here on our website, you can call MODA, you can also talk to your pharmacist, right? So if you are getting prescription drugs and you have questions, you can always go up to them and ask them, right? Because they're a trusted partner, you're seeing that pharmacy, they know your medications, they'd be more than happy to help you understand some of those other issues.
MODA gets a decent amount of, a decent percentage of their phone calls are actually from pharmacists. And it's nice to look at those reports to know that so many pharmacists care about their members enough that they're not just saying, oh, you should call the number on the back of your ID card. They're actually doing the outreach and reaching out to MODA to verify drug interactions or verify coverage or, oh, this member had this side effect type things.
But it's overwhelming.
It is overwhelming and we're
At
constant.
bare minimum, it's overwhelming.
Yeah, I will give kudos to our communications team, because we all the time, I'll be like, I got members that asked about this and they don't know how to find this. We should put it in all the things and put it everywhere. And they have to be tough all the time, and because they've got, a lot of us coming at them with different ideas, and they have to sometimes say it's too much. It gets buried in the details. We need to provide the information that has the most impact to the largest amount of our members. Providing links to the COCs or links to the PDL and things like that. So it's hard.
We've recently updated our website to make it more modern and the search engine behind it. And we do look at the analytics on the search engine, so that if people are asking for specific things that are sort of buried deep in the website, then those things are moved to the front. So we're getting better. The old website was fairly brutal. The new website is much more intuitive, and it's getting better.
And we do try to hit like WCAG, is that how you say that? That's the ability for people with disabilities to use and understand our materials. Our communications team is big on that. And so running testing scenarios for screen readers, and we actually work with some community members that have reached out and said, hey, I can't use your website because I have to use a screen reader and it just takes me on a loop. And so we've actually sought out the input of those people that reach out and said, hey, we're testing. Do you mind going in and testing and giving us some input on where we're at?
And a proud moment for HCA. We worked with the governor on his plain talk executive order. So he put out an executive order saying we've got a plain talk government to people to understand, and Healthcare Authority was one of the primary authors. So the head of our communications department is very much into plain talk, providing information for people to understand, and actually working with other agencies to help them get there. So work in progress.
And I think we need this more than ever, because at least my experience recently has been, and I was not in a situation, a dire healthcare, knock on wood situation. We go to a pharmacy and it's Walgreens, CVS, or Safeway, and they say, look, I have to handle the people in the cars, and I have to handle this. I don't have time to talk to you. Here's the medication. And I'm like, well, but, and they're cutting back at some of those chain pharmacies, and people don't know that. So you come in, as like you said, you have something wrong. You have an infection and you want, oh, no, that's the safe way on the other side of Olympia. You're not, okay, it took me an hour to get them to tell me that. It's just because they're overworked. Okay.
Okay. The next slide gives a little bit more detail. Oh, I'm sorry.
I've had my hand up for a while, but I guess that's the problem with being in the Zoom instead of in person. So Jenny, I have a question. When your doctor said that this would be a good medication for you to take, I'm assuming that that doctor does not bother to check where it is in the system, whether it's a specialty. He just said this would be a good medication for you to take. Is that correct?
No, actually, my doctor explained to me that it was going to come from a specialty pharmacy and that it wasn't actually covered under my insurance. And explained that Arden Health, the specialty pharmacy, could work with me on some reductions in the cost, because that's a service that Arden Health also offers, is some cost services to reduce the cost of medication. So like they're like manufacturer rebate type of things. And so my doctor knew exactly where the prescription was going and gave me a lot of information. So I wasn't surprised when Arden Health called. Yeah. And they actually were the ones that when they called me, they said, this isn't covered by your insurance. Would you like us to look at what cost options are available for you? Because there were two options. There was one that was an option that was, covered by insurance, and the one that wasn't. Because of my special needs, the one that wasn't was the better option for me.
So I guess what I'm trying to wrap my head around as I look at this process that drugs go through in order to get placed on the formulary, and looking at all of the, there's so many, it's a very complex process. So I guess my question is, when a new drug comes on the market, and 2 slides ago when you had all of those different responsibilities that like Arden does and Novice does, when a new drug comes on the market, where does it go first? Does it depend on the type of drug it is? Like some drug might be a specialty drug, some might be a tier 1 drug, some might be a tier 3 drug. How does that, when you look at that slide, where does it go? Who makes the determination as you work through that process?
I'm gonna have you hold for a minute because on that question, because Ryan has a series of slides dedicated to that entire topic. So just hold on until we get to Ryan's part of the presentation.
I just want to remind staff, we're on slide 12 of 35, and we
Started early.
we started early, now we are getting behind, so just a heads up.
Dave originally gave me 45 minutes, or gave us 45 minutes. I was like, I don't know, I've never hit my timeline. So, okay, more to come on that. So thank you for that question. This slide gives more information about Arden. I'm gonna move past it. We really talked about most of that already. So this slide here talks about Washington State Prescription Services / ArrayRx. So Washington State Prescription Drug Services, it's just a name that was given to UMP to kind of as a name for our UMP pharmacy services back in the day, because we couldn't call ourselves the Northwest Prescription Drug Program. Nobody knew what to call it. And it's just been a name that has caused confusion more often than not with people. With the rebranding of the consortium to ArrayRx, we are also rebranding WSRXS to ArrayRx beginning 1/1/25. So that will be a change that people see on their ID cards. It'll now, instead of saying WSRXS, it'll say ArrayRx. And that just aligns with the program. It aligns with some web addresses and stuff that we have for members, just to make it more clear for people. So this is to let you know about that. And to wrap it all up, ArrayRx is the group of vendors and products that make up the UMP pharmacy program. As confusing as it sometimes can be, as we've seen today, ArrayRx is the group. So if you look under ArrayRx, we've got MODA with their subcontractors, with UMP using that contract. Alrighty. And then next slide, I know Elliot's asked in the past, okay, if all your contractors do all that, then what are you guys doing? We're not just sitting at desks watching screensavers. We're doing a lot of work in oversight of our Moda Health UMP participating program agreement. So we have to hold them. We hold them to the contractual requirements of that agreement that we have with them. We also do a lot of data that's delivered by Moda Health. Brian talked about some of the data that he looks at in the reporting portals, but we look at those to make sure that our programs are being administered in an equitable way, that policies are being adhered to, and that our members are getting the services and products they need from our vendor. They provide us, like I talked about before, they invoice us, so we do verification and approval of those invoices. We get a lot of supporting information to make sure that what we're paying them is the correct amount. We review rebate terms and reimbursements. Again, Ryan's going to have a lot more information here soon on rebates. We do member exception request reviews and determinations. So talking about the PDL, or I think Elliot, you mentioned, you know, the secret drug coverage or whatever, a secret list. That we have the PDL, that's our approved list of drugs that are covered under the plan. If there is a medical necessity for you to take a drug that's not excluded would be mean a drug that's not safe, right? Or it's investigational or something like that. But if there's a need for you to take a drug that's not on our PDL, you can accept an exception. So maybe you've tried the alternatives that are on the PDL, or your doctor's like, the drugs that are on the PDL are gonna negatively impact your health, you need this. So a member would submit an exception, or the provider actually would submit the exception. And we look at those come to Ryan and his team actually to look at the clinical efficacy of what's being asked for coverage of these drugs that are not on the PDL. We make the benefit design determinations, and you guys have a huge part in that when we bring new benefits to you that you guys are voting on. We've looked at those. We're making those decisions on this is what we want to cover. We want to cover COVID test kits at 0%, $0 cost share. It's not part of your business at MODA, but that's what we want to do. Things like that. We make these decisions and then we tell MODA, this is our decision, and then do it, right? We handle member inquiries. So like it's been talked about today, you can call MODA. MODA is a great resource for finding out, is a drug covered? Is my pharmacy in network? You know, I'm going out of country, so I need a bigger supply than just 1 month supply. MODA's great, but if you have a question about what MODA told you, or you have a concern, or you want to share information about enhancements for the benefits, why don't we cover this drug class, type of things like that, members do reach out to sometimes the board, sometimes the governor's office, sometimes directly to us on the UMP team, and we handle those inquiries. A lot of times that's actually reaching out to MODA to say, this person says they were denied this PA. What can you share about that so that we can best serve the member? Or this member's specialty drug was delivered. This is like literally never happened, but this member's specialty drug was delivered late and it was above the temperature that it has to be kept at. We can, although a member could call Arden or they could call MODA, they could call us and we will work with them on their behalf as well. We don't just shuck them to the MODA, will help them directly. And then the preferred drug list, Ryan reviews and makes determinations on the preferred drug list changes. And like, I didn't catch the name of who that was on the phone, but like we mentioned earlier, he's going to talk more about that in coming slides. All right, I've kicked my speaking into fast mode, so I apologize. Feel free to pop in. So moving forward a couple slides, we're going to talk about pharmacy benefit managers and what they are and what they do. So PBMs have a set of specific things that they generally, or that they do offer to carriers and administrators. So they do claims processing, they manage formularies. For UMP, we call that our preferred drug list. They create and administer the network of pharmacies. They provide utilization management services. So that would be like pharmacoadherence programs and things like that, where we're making sure that people are using their drugs as indicated. They operate the mail order pharmacies, as we've talked about, and they administer rebate programs. Again, Ryan's going to go into more detail today about rebate programs for UMP. On the next slide, this is an interesting one that I think people will enjoy. So, I'm going to put it out there at the very beginning. ArrayRx is a pass-through transparent model. So that light blue, it almost looks like a little dude standing there, right? The light blue one.
Transparent.
Yes. Oh, hey, the transparent. Oh, geez, you'd think I'd know since I made this slide. Anyway, so ArrayRx does use the pass-through transparent model. That's something that ArrayRx steering committee, that's a requirement in their contracts and in their request for proposal when they go out. And so the pricing model here with traditional, we call them spread model PBMs, they capture a spread. So what that means is they do the negotiation with the pharmacies, they do the negotiation with the manufacturers, they negotiate the rebates, and then they keep a portion of that. They keep a portion of the spread, whether they charge a pharmacy or they charge a carrier or a plan $10 for a drug, but it only costs them $5, they would keep that spread, right? Or, you know, they administer the rebate program. They say, hey, guess what? You're going to get $2 million back, but really they're keeping $3 million, right? So they don't pass through 100% of that. With Novitas, with our pass-through model, it's 100% pass through to us. So we get 100% of the rebates. What is paid at the pharmacy is what we pay. UMT pays, so we're not paying above what the pharmacy is paid. PBMs make money, obviously, well, like the traditional model is making money through that capturing spread through rebates. They also charge administrative fees. With the pass-through model, we pay an administrative fee. So they're not making their money through spread. So we pay a fee for them to offer these services to our members. Advantages for a payer. Under our pass-through model, we have maximum transparency. So we can audit. We get to look at, we're actually going to be going through an audit here soon of some of this information, like what were the rebates that were collected? Did we really get 100% of those? Because you're not going to get that option in a traditional model. That their contracts and their agreements are held very closely. They don't allow for auditing, where in a pass-through model, you are allowed to look at audits. And there's cost control under the pass-through model because we're only paying for the drugs that people get. We're not paying an additional percentage of the cost of the drug. You have the administrative fee, but there's cost control in that. Some disadvantages, obviously, like I talked about with the traditional model, there's lack of transparency and there's potential for abuse there. And I think, Elliot, this slide is really based off some questions that you had at previous board meetings about, what you're hearing in the news, and that people have this view of PBMs as abusing members, abusing payers. And so that's something that can happen with that traditional spread because you don't have that transparency of how the program works. And then a possible disadvantage with the pass-through model, like what we have, it can be it's an administrative burden, right? Because we can run audits. It's managed much more closely because we have much more view into it. And not for us, but more for MODA working with Novitas, the negotiations take a bit more because with a traditional model, those PBMs say, this is what we offer you. It's what you're going to get. There's not a whole lot of negotiating in that. MODA is expected per their contractual agreements with the RARX, they're expected to negotiate with Novitas. So it does take more time on their end. Any questions? All right, I'll continue talking fast through this next slide. So again, this is just more information about Novitas versus the traditional PBMs. The traditional has maximum allowable costs, multiple maximum allowable cost lists. So the MAC list, where Novitas has a single MAC list, this maximum allowable cost list is an industry standard list of what should be paid for drugs. And so that way pharmacies know what they're paying, plans know what they're paying, and the benefit administrators should know what they're going to be paying as well. And using multiple lists allows for a bit more possibility in what we were talking about with maybe the PBM using a list that more aligns with how much money they can make versus what's best for the plan and what's best for the member. And our MAC lists under the 100% pass-through model are updated weekly. And so drug prices change a lot, very, very often. And so our single MAC list is updated weekly to make sure that we are paying the correct amount for drugs and that members are paying the correct percentage for drugs. Traditional models, like I said, spread on rebates and that max savings. We talked about it's 100% pass-through with Novitas. We talked about the audits. 100% pass-through is fully auditable, and there's a lot of restrictions under the traditional. And then the ownership of the companies. Traditional PBMs are often publicly traded on Wall Street, and with that comes a lot of expectations for the amount of revenue that they are making. And Novitas is a privately held corporation, so they don't have that those Wall Street expectations. Next slide just again goes over a bit more how Novitas differs from the traditional PBM model. We talked about them being a pass-through. That does help to keep premiums low for members, right? We're getting 100% of the rebates that are owed to us instead of leaving a bunch of those on the table for that PBM to take or keep. And it's a huge driver in our ability to maintain cost control for members. They use a high performance drug mix, which is like low cost generics and less expensive brands. They're constantly looking at how can we control costs, because we want to deliver low net cost and reduce our PMPM administrative expenses for our premiums. And we talked about the MAC list and that they pass through 100% of all rebates. So there are obviously a few different points that I wanted to really drive home because they're in 3 slides all at once. I think that brings me to the end of mine. I know I talk really fast. I don't want people to feel like they can't ask questions because we're kind of behind. So feel free. Sharon, I saw notes. You're good. Okay.
One thing I have noticed is often if you don't have a, what do you call that, generic equivalent, you won't cover the original drug. And so that saves you money too. I mean,
Yeah, so that's something that we've had, you know, for a long time within UMP since even before I started working on the plan. So, you know, we've had that kind of as a core principle for UMP.
Hey, I apologize, Ryan. I hope you're ready to talk real fast.
Ryan, don't feel obligated to complete stuff.
So good morning, Chair McDermott, members of the board. My name is Ryan Distressy, and I'm the Assistant Chief Pharmacy Officer here at Healthcare Authority. So my 2 topics today are around P&T committees and around rebates. So Tom, you know, going back to your question about, you know, how do drugs get their tiers, the way that I would answer that is by talking about P&T committees. So on the next slide is a high level of what does a P&T committee do. So P&T committees make decisions on where drugs are within a health, right? So all of the drugs that are on the UMP PDL or that are on our Apple Health PDL for our Apple Health population, they go through a P&T committee where we have a group of clinicians who review clinical trials and other evidence around the safety, efficacy, and effectiveness of drugs. And they use that information to then make a judgment of saying this drug should be preferred or this drug, you know, should not be preferred. These P&T committees are not limited to just the clinical trial information. They may consider other things like cost, prior authorization criteria, actual utilization of the drugs, and other information related to the drugs in the health plan that they're evaluating. And P&Ts are found at all levels of healthcare throughout the United States. So we do have them at the federal level, at the state level, which we'll go into, at the health plan level, which we'll talk about MODAs, and even hospitals or jails or other facilities will have their own P&T committees in order to establish what drugs will they carry and administer or dispense to their patients. So for UMP, we talk about it in 2 ways on the next slide. And it's described in our COCs. So for drugs that are part of the Washington Prescription Drug Program, which Jenny mentioned in her presentation, right? That's the one that administers it for multiple state agencies. That is the Washington P&T. For all of the other drugs for UMP, those go through MODA's P&T committee. So the Washington P&T committee is administered under our prescription drug program, and that is called the Washington Preferred Drug List. This is a drug list of about maybe 35 drug classes that range about maybe 300 to 400 drugs for UMP. But this is one that is combined between different state agencies. So labor and industries, for example, the drugs that they cover, they participate in this Washington Preferred Drug List. MODA's P&T committee reviews all of the other drugs, and this is considered what is called a wrap, because it wraps around the Washington Preferred Drug List. So this is most of the drugs that are on the UMP PDL are reviewed by MODA, but there is that specific subset based off of statute that we review under the WPDP. On the next slide is the citation for that. So it is law that the state has to have a P&T committee. And that was, covered earlier with the timeline that Jenny presented, back in 2003, when this bill became law, We created this program in around 2005, and multiple state agencies were a part of this. It's administered under WAC 18250. So if you want to see the rules of how that program operates, and the committee is made up of licensed providers in the state. So our current makeup is 4 physicians, 4 pharmacists, 1 nurse practitioner, and 1 physician assistant. And what's nice is our P&T also serves our Apple Health population as their drug utilization review board, which is required in the Social Security Act, Section 1927. So Medicaid specific stuff. On the next slide is just a bit more information about that. So our P&T and DOR board meetings are open to the public, just like this. In fact, we do set up in this room with the same horseshoe shape, and it is available on Zoom. So if you are ever interested, we do have those meetings available for you to attend virtually. The link there on the slide lists our upcoming meetings and materials. We have one, in fact, later this month on the 26th. And we convene 6 times each year on even months. So our next one after the one in June would be in August. We get our evidence from a third party. So it's not the clinicians here at HCA that are doing these reviews. We have to have the appearance of being, unbiased. And so we do go with an outside entity, which is called the Drug Effectiveness Review Project. They're out of the Oregon Health and Sciences University in Portland, Oregon, and they provide a lot of evidence reports for different states. So they also serve Oregon, Colorado, Idaho, Louisiana, Wisconsin, Michigan, a whole host of states for drug evidence reviews. We present these DERP reports and other evidence to our P&T committee, and after they have reviewed the data and had their questions answered and get input from the public, the public does get to provide a public comment. Then they make a motion, and that motion is the decision from that P&T committee about that group of drugs. So once that's done, we go into the next step. So on the next slide is the description of how that decision translates to a tier on the UMP. So once we have that motion, the state agencies perform the cost analysis, looking at the prices of the drugs, the utilization, and rebate offers from the manufacturers to best understand how to structure the Washington preferred drug list and subsequently the UMP preferred drug list. So the state agencies that currently are part of this are Uniform Medical Plan and Labor and Industries. Apple Health was part of this from 2004 to 2017. But with the legislation that created a single Apple Health PDL, they pulled out of this process. But just if you look at older PDLs, just know that Medicaid is part of that. After we and LNI have come to an agreement on what we feel should be preferred and non-preferred, we send out an agency director's memo, which announces the decision, and MOTA takes the agency director's memo and updates the PDL accordingly, and any subsequent processes like, any member communications that need to go out, any updated PA criteria, any change in cost shares, things like that. MOTA does all of that after we've finished our process for the Washington P&T. Any questions at all before I move into the MOTA P&T? Okay, so the MOTA P&T is very similar in a lot of ways. So on the next slide, you'll see that each week MOTA does their review. So unlike our Washington P&T, which meets only 6 times a year, MOTA's team reviews new drugs as they come to the market every single week. And these include things like new generics. So when a new generic comes out, that gets reviewed. If there is a line extension, which means that there is a new strength of an existing generic coming out, they review that as well. But what they really are doing, with these is to identify new biologic or new molecular entities. So these are drugs that are newly approved by the FDA that are the first time on market. So these are the new brand name drugs or the new biologic drugs that you may hear about with the jingles that they've mentioned earlier. So they start to gather an initial clinician review. So they're looking at the clinical trials, the FDA medical review, the clinical practice guidelines for that disease state, a manufacturer dossier. So that's the information from a manufacturer that lists everything about the drug. including a lot of chemical processing, manufacturing, distribution, storage, supplies, all that. And they bring that to their P&T committee. And MOTA makes sure that they do review all of these new molecular entities within 180 days of market entry. On the next slide, we have a bit more information about that process. So once they've completed that clinical review and the P&T committee reviews that data, they have three options for their vote. First is they may prefer or must add, they do not prefer or do not add, and they may prefer or may add. So the difference between add and prefer is like with us for a preferred drug list where we can prefer and non-preferred drugs. For their Medicaid lines of businesses, it's add because they do have to add drugs for Medicaid under CMS rules. MOTA's P&T, they also do formulary management activities, so they also will review prior authorization criteria. So they're not only looking at whether this drug should be preferred and what that cost share should be, they're also looking at whether there needs to be step therapy, prior authorization. They do retrospective drug reviews, but they have to do this in order to make sure that they are understanding what types of effects these decisions have on access, to these drugs. On the next slide is how we get that information from the MOTA P&T committee. So after they've completed that review, MOTA provides a summary of those recommendations to UMP for us to consider for the UMP PDL. So as Jenny mentioned, this is one of the roles that we reserve under our contract with Array RX, that we get to make that final decision for the UMP PDL. For most of the decisions, we will agree with MOTA because they've gone through that and they've made a decision that we feel represents, how the UMP program should administer it. But we also have different laws and regulations and other program considerations in our state. And so we do take that into consideration and may say, well, your recommendation was not to prefer this drug, but we have a law in Washington that says that it must be preferred. And so we must make this change in order for our UMP PDL to be compliant with state law. So once we report that back to MOTA, MOTA makes the updates and the UMP PDL is updated accordingly. Next slide. So a couple examples of recent ones. So this year we had a few new bills that passed the legislature and got signed by the governor. So the first one is updating cost shares for epinephrine auto-injectors and inhaled corticosteroids for asthma. So we are making updates to the PDL for January 1st, 25 to make sure that we are compliant with that. And then there was another Senate bill that removes cost sharing for at least one regimen used for post-exposure prophylaxis for when someone is exposed or potentially exposed to HIV to prevent them from then developing HIV. So that's it for the P&T section. Any questions before you move into rebates?
Just a reminder that the entire P&T committee piece that you just described with MOTA is a weekly affair. And that's a key part that's an administrative function of the agency because of the frequency of the drug pipeline and the amount of churn that is happening.
Actually, let me clarify. So the weekly component is the clinicians doing the review of all the new drugs. And they will identify a new drug that needs to go to P&T each week. So MOTA's P&T committee is not every week. It is going to be monthly or monthly to quarterly, depending on the drugs. But that review of all the new drugs that come to market and making a decision of whether it should be tier 1, value tier, tier 2, non-covered, that's done each week. So thanks for the clarifying point. I must have misspoke earlier.
No, I'm just trying to add color.
Okay.
But we're behind, so I'm going to stop.
Okay, no worries. So let's move on to the rebates. So next slide, actually one more. So there are many different types of drug rebates. But for the purposes of this presentation, we'll focus ones that really apply to UMP or the commercial world. So we're not going to be talking about Medicare until the very end or about Medicaid, but just know that those are slightly different. So when we're talking about rebates, there are two different types. There are the standard rebates that are the most common, but there are also value-based rebates that are becoming more and more common within industry. The standard rebates are just a percentage off of the cost of the drug, whereas these value-based rebates have other considerations within them, looking at volume-based discounts, clinical outcomes in case that someone is taking a drug and they don't get the desired outcome, the drug manufacturer would refund the cost of that drug. So there are these new innovative rebates that are coming out, but they are less common due to some challenges that occur with, actually the slide should say Medicaid best price, not Apple Health best price. I think that was a typo, but Medicaid best price, which is administered by CMS, or the Centers for Medicare and Medicaid Services. So rebate agreements that we review as part of our cost analysis that we do under the Washington P&T, we have to consider some of the conditions that come with that. So rebates that come from manufacturers often carry a lot of terms and conditions with them around their placement on the PDL, their competitors' placement on the PDL, and sometimes prior authorization criteria. So a manufacturer, for example, may offer a 30% discount if they're the only preferred drug on the preferred drug list and that their competitor is not covered. But they may only offer a 15% discount if they're preferred as well as their competitor that's preferred. So there are different terms that these manufacturers use in order to make their drugs more kind of exclusive on the different PDLs. In terms of prior authorization, they may say that you cannot require a member to step through, drug X before they use their drug, or they would have a lesser rebate. So there's a lot of considerations that we review in our cost analysis around these rebates, and that does impact the structure of the UMP PDL. On the next slide, we talk about some of the administration and oversight that we do with MODA. So as Jenny mentioned, yes, we do get 100% of those rebates from the manufacturers. It's in the contract between ArrayRx and MODA, and then MODA and all of their subcontractors. So the teams that they work with to contract with these rebates, they do make sure that that is 100% of that pass through going through them to us. We do get quarterly reports from MODA. So as Jenny mentioned, that portal that we get from MODA that has the analytical tools, one of those reports that we are able to review is around the detailed rebate information. So we can actually see what those claims are, what the drugs are, what the manufacturers are, what the rebates amounts are. And we can actually go back and say, okay, here's the amount that we got. What did we forecast in that cost analysis, and double check and make sure that we are getting as good, if not better, of a rebate deal that we were reviewing when we were making those PDL decisions. And so we do work together, for the rebate program integrity, as Jenny mentioned earlier. We are going to be doing an audit soon. So this is another thing that we do here at the agency to ensure that the program is running efficiently and effectively for our members. Okay. Next slide is a little bit more information about how rebates impact premiums. So because UMP is a self-funded plan, that means that HCA, on behalf of the PEB and SEB program employees, is responsible for paying all of the UMP medical and pharmacy claims that are incurred by the members. And UMP's contracted pharmacy, team MODA, processes, but is not at risk for all of the pharmacy claims expenses. It's worth noting that rebates can be received up to 18 months after an eligible pharmacy claim has occurred. That is due to some disputes that may occur between the manufacturer and our rebate aggregator. And so that may take some time for them to resolve. There are some, drugs that may go through UMP that may not be eligible for rebates. You may have heard of 340B, but I won't get into that today. But just know that there are some other complexities that go on behind the scenes, and that does delay. So we don't necessarily get the rebate at the point of sale when someone is receiving their prescription. It's usually 6 to 9 to even up to 18 months after. So just know that there is a lag between when a claim occurs and when we get the rebates from the manufacturer. But we use that to make sure that 100% of those rebates are received, and we use that to offset the claims expenditure for future periods. So when someone gets a drug with a rebate today, just know that that rebate is going to be received in the future and used to offset, premiums in the future.
And just highlight, Tanya will be here for executive session, but she could highlight that we do have a forward projection system that we're anticipating the rebates, and it's the truing up of what the actual rebates were versus what the projections were, and if there are adjustments that need to be made in either direction, upward or downward pressure based on those rebate assumptions, that is rolled into the annual premium setting process.
Thanks, Dave. And then, we typically are looking at the lowest net cost to the plan, that helps then limit premium growth. However, there are some situations in which, there may be a state law or something in which we have to, cover a drug which may or may not have rebates associated with it. And I believe the last slide is around Medicare Part D. So as you know, we are working towards a new Medicare Part D offering for our UMP Classic Medicare. And we just want to reiterate that this will have a different PDL and rebate structure than the current UMP Classic plan. This is because Medicare has different rules and regulations. It's no longer needing to be necessarily compliant with the state law. It has to be compliant with federal laws. And so there may be some changes in what is going to be preferred and non-preferred, or what, we receive a rebate on or not. The new UMP Medicare Part D plan will be paying lower amounts for the drugs as part of the new Medicare drug price negotiation program. And for those of you that are very interested in this, we will be getting a new updated list in August of this year about the new drugs that will be added to that drug price negotiation. So that is a new type of rebate that we can't get under UMP Classic that we will get under D. And another kind of more immediate and exciting thing that's actually been having a lot of impact in industry today is a new consumer price index penalty that will be applied to Medicare. So this went into effect earlier this year for all Medicare plans, and it's having actually a very significant impact on drug pricing within Medicaid, Medicare, and the commercial world this year.
Simple enough. You wonder, you're like, why does that have to be, why does that have to be this way? Why is it so complicated? Well, it's a $1.5 trillion business worldwide. And when you have that much money involved, they're gonna hire the smartest people they can. They're gonna influence the political system and the laws. And you wind up basically having to play a little cat and mouse with the industry as they make a move and we make a counter move, and it goes back and forth over the years. And whether the political forces, will ever unite to the point where they address some of these complexities, because the more complex it is, the more room there is for inflation and money to bleed out. And but we do our best with what we have, and our state is set up better than most in what we do. As a matter of fact, a lot of the initiatives that we do with MODA are then spread to other states as we go and share our experience with what we've done and how we've done it. So a lot of times other states are calling us saying, what are you guys doing about X that just happened? We led a lot of the efforts related to Sovaldi.
Yeah,
Hep C, the first one, hepatitis C, Sovaldi was a cure, but in the beginning, it cost as much as a small house per person. So there was a lot of, how are we gonna control this? How are we gonna do this? And I think Washington State led the charge with our plan on how we administered it. So super, super complex field. Sorry, we kind of had to rush near the end. I appreciate it. Board members, any final questions for Ryan or Jenny? Why don't we take a 10-minute break? What time is it right now? 11:15. How about 11:25? We'll come back and hit it again. Ryan, Jenny, thank you so much. Appreciate it. Thank you.
That's okay. Next slide. So today we're going to talk about the UMP with Part D implementation. I'll give you an update on the communications timetable, and then we'll do a very brief discussion of international prescription drug coverage. And then I will pass it off to my esteemed colleague, Stella Yang. Next slide. So we are currently preparing for the migration of current UMP Classic Medicare members. So members who are current enrollees in UMP Classic Medicare who want to stay in that plan do not have to fill out a form or take any action. We will automatically move them over to include the Part D coverage. Members who need to make changes can do so on their benefits 24/7 accounts, such as adding or dropping a dependent or adding or dropping dental coverage. Next slide. In terms of the timeline, in May, there was an article in the PEB retiree newsletter about the switch to Part D, and I know that a lot of people read it because I have a mailbox that's dedicated to UMP Classic questions, and I've gotten a lot of questions, so I know that that was well received. We've also made updates to the retiree engagement webpage. Now through August, we are finalizing rates, specific formulary information. As you may recall, the Part D formulary has to be approved by CMS, and that will take place over the summer. In September, we'll start doing the letters to current UMP Classic Medicare subscribers. We didn't want to do it too early because by the time open enrollment arrives, they may forget things. So it would be in that timeframe, early fall. And the MODA drug lookup and pricing tools will be posted at that time before open enrollment. Next slide, please. So there is a change in open enrollment dates this year. It was announced in the May newsletter. The main reason for doing this is to ensure that there is support for members making changes. In the past, we've heard concerns from people about the Thanksgiving holiday, and if you were waiting to the last minute to do your open enrollment changes, it was hard to get staff available to answer questions. So open enrollment will always start the last Monday of October and will always end the Monday before Thanksgiving. So nobody has to worry about the Thanksgiving holiday. And for this year, the dates will be October 28th to November 25th. Just a reminder, forms have to be received by HCA by November 25th.
Just one more piece on the open enrollment dates being shifted in the PEB program. We know from our historical data that about a third of all plan changes are made in the first 48 hours, and about a third of another third are made in the last 48 hours of open enrollment, and a third in however many intervening days there are. And so you can see in the data year over year that as the Thanksgiving holiday approaches the end later in the month, because it's always the fourth Thursday of the month, that we see less involvement in our systems and engagement on those final days of open enrollment and more appeals. And so there was a direct relationship looking forward to the calendar to go as we start to get to and even employers would reach out to us. And we even had this last year in January. After open enrollment was over, we had a couple of employers said, "Hey, Thanksgiving's late this coming year. Will you guys think about the implications of that?" I'm aware that historically some agencies and entities, higher education institutions will even have volunteers who would come in over the Thanksgiving weekend to be supportive of their members. And that just felt like the wrong environment to be setting up. The other advantage we have is this will always add a couple extra days buffer for cleanup. It always takes longer to do the file transfers. It will help everyone be more likely to get new cards in time for January 1st. It just gives a little bit extra buffer.
Next slide, please. So in October, you can see there's a lot more activities that happen as we gear up for open enrollment. There'll be the customized, what we refer to as the customized retiree letter. So just as a reminder, this is the letter that goes to retirees, and it indicates this is what plan you currently are enrolled in. Here is the premium if you want to continue in that plan, and here are alternative plans that would be available. And then we're going to add some more information this year as well. There'll be a retiree newsletter that comes out in October. We will have updated retiree open enrollment packets. Those packets include not only the information of how to enroll and what the different plans are, but also the forms themselves. The UMP virtual benefits fair webpage will be updated. And in-person benefits fairs will start. The last sentence should say open enrollment begins October 28th. I apologize. And so there's a lot of activity that's going to go on to be sure that we are prepared for that. And then in November, again, open enrollment ends on the 25th, and once again, forms have to be received. This is a very important component that I like to emphasize as much as possible because we always get questions about, but I postmarked it. No, not good enough. It's got to be received by HCA. You know, it's like the bank statements or billing statements that we get from our credit card. Please allow sufficient time to be sure that we receive this on time. Now I'm going to switch and talk about international coverage. And next slide, please. As we switch to Medicare Part D for UMP, it's important to remember that there are rules that pertain that are based on Medicare rules. So PEB program rules say that for retiree insurance coverage, you must be enrolled in Medicare Parts A and Part B. But Medicare is a federal health insurance program, so it requires a US address. The US territories are included, and there are some very limited exceptions for international addresses. But prescriptions filled in a foreign country cannot be covered by Part D. There is an exclusion to all Part D plans. This pertains to commercial Part D plans, EGWP Part D plans, Part D that is part of a Medicare Advantage plan, Part D that's part of any other plan. All Part D plans exclude prescriptions filled in a foreign country. You cannot do that under Part D. However, you can get a travel prescription, as Jenny mentioned, if you're going to be traveling and you need a fill for longer than your 30-day prescription, you can always get up to 90-day supply. And we call those a travel prescription, and that gets filled in the US prior to leaving. And then you have the drugs available for you in a foreign country. Next slide, please. So the impacts of this are, there are currently fewer than 20 PEB program Medicare members who have an international address as their primary address. Because there's a Medicare exclusion for foreign addresses, even if people are enrolled in Medicare Part A and Medicare Part B, they're not really taking advantage of Medicare Part B because you can't have those services outside of the country, although you can pay for it if you want to. But you cannot be enrolled in Part D. That's a much tighter restriction on the Part D. And therefore, we need some policy resolutions from the board. And therefore, it is my pleasure to turn it over to Stella Eng.
Good morning. Good morning, Chair McDermott, members of the board. My name is Stella, Policy and Rules Coordinator in the PEB division. Next slide, please. This slide and the next slide are included in the presentation, so the board will have them available for the policies we will discuss. Yes, thank you. We have two proposed deferral policies to introduce. The two proposed deferral policies address Medicare subscribers who permanently live in a location outside of the United States. Our goal today is to introduce these two policy proposals to the board, get your initial feedback, and prepare the board to take action at the next board meeting. Next slide, please. Before we discuss the two proposed policy resolutions, I would like to give you some background on the deferral policies that the board adopted previously. Currently, the following individuals may defer PEB retiree insurance coverage: a retiring employee or retiring school employee. They have two decision points upon retirement. They have to decide whether they wanted to defer or enroll in PEB retiree insurance coverage. And the dependents becoming eligible as survivors, and as well as retirees and survivors, they may defer PEB retiree insurance coverage. To defer, it means to postpone initial enrollment or interrupt current enrollment in PEB retiree insurance coverage. And when they defer enrollment, they also defer enrollment for all eligible dependents. So this is to provide the pre-Medicare and Medicare retirees and survivors with full choices without causing them to lose their PEB retiree insurance coverage eligibility. Next slide, please. So the board adopted most of the deferral policies that allow retirees and survivors a one-time opportunity to return from deferral with qualified coverages within the same period. This is to limit the risk of adverse selection from those who return. There may be a small gap in coverage when they change between qualified coverages, and the board recognizes that. And so Resolution PEB 2021-14 was adopted to allow a gap of 31 days or less between each period of enrollment in qualified coverages during the deferral period. And I've placed Resolution PEB 2021-14 in the appendix for your reference. The re-enrollment timeframes vary based on when the enrollment occurs. They may enroll during the open enrollment and coverage begins January 1st of the following year. Or they may enroll when a special open enrollment event occurs. So generally it's no later than 60 days after that, that coverage ends. So next slide, please. So the board adopted deferral policies for PEB retiree insurance coverage starting 2001. And so here's this slide and the next slide include a list of qualifying coverages, and I'm gonna go over them with you. So in 2001, the board allowed employer-based group medical or such medical coverage continue under COBRA or continuation coverage. The board also adopted in the same year in 2001 to allow federal retiree medical plan as a qualifying coverage. In 2006, the board allowed Medicare Parts A and B and a Medicaid program that provides credible coverage as qualifying coverages. And the credible coverage is different than the Part D credible coverage. This ties with the Insurance Commissioner's definition of credible coverage as described in the statute in RCW 4866-020. That includes payment of medical and hospital benefits. To put it in layman term, that refers to the full benefit dual eligible for Medicare and Medicaid recipients. Next slide, please. And in 2014, the board allowed exchange coverage. So for those who are not eligible for Medicare Parts A and B when they're enrolled in an exchange coverage. So this typically refers to the pre-Medicare retirees. And then the last one that the board adopted was on July 17th of 2018. So when the subscriber is enrolled in the CHAN VA coverage.
So the long story short is there's a strong history behind the deferral policy. Stella just went over the various coverages that are allowed, and then I think the most recent iteration and change by the board was allowing that 31-day gap. And as a reminder, the way to think about that is a retiree might want to defer their coverage of PEB while they go on their spouse's other employer-sponsored coverage. I'll just pick a company, we'll call them Boeing. And they might go onto Boeing coverage. And then when their spouse retires or leaves Boeing, and I'm not sure if Boeing policies are actually in this, but their coverage may end mid-month. In PEB, we always end everything the last day of the month and begin things on the first day of the month. But that's not how all employers work on insurance. They may go on the pay period for the exact last day of the employee. And so there were instances where someone would lose that employer-sponsored coverage mid-month. They couldn't come on to PEB until the first of the next month. There was a gap. And that's what the board last recognized as kind of the most significant policy development of the deferral. But now we have international coverage. So back to Stella.
So that brings the two proposed policy resolutions. The first proposed resolution, PEB 2024-26, addresses Medicare retirees and survivors who permanently live in a location outside of the United States. As Ellen mentioned earlier, Medicare Part D coverage is only available to individuals reside in the United States and US territories. An individual who lives abroad permanently is not eligible for the UMP Classic Medicare plan, as they do not meet the Part D eligibility requirement. Currently, we have fewer than 20 Medicare subscribers enrolled in PEB retiree insurance coverage who live outside of the United States permanently. This proposed resolutions allows them, as well as future Medicare retirees and survivors, the option to defer if they choose to permanently live outside of the United States. Under federal Medicare Part D rules, a proof of qualified coverage is not required for enrollment when moving from a foreign country to the United States. The special enrollment period permits enrollment elections only, so it begins on either the date of the permanent move or on the date the individual provides notification of such move. We recommend waiving evidence of continuous enrollment in a qualified coverage to align with CMS Medicare Part D enrollment requirement. Those who return from deferral can enroll by submitting the required form and proof of enrollment in Medicare Parts A and B. And the proposed resolution reads, proposed resolution PEB 2024-26, PEB retiree insurance coverage deferral, permanently live in a location outside of the United States. Effective January 1st, 2025, retirees and survivors who are enrolled in Medicare may defer enrollment in a PEB retiree insurance coverage when they permanently live in a location outside of the United States. Evidence of continuous enrollment in a qualified coverage is waived while a retiree or survivor enrolled in Medicare lives outside of the United States. A retiree or survivor enrolled in Medicare who defers enrollment while permanently living outside of the United States will have the opportunity to enroll in a PEB health plan when they return to the United States by submitting the required forms and proof of enrollment in Medicare Parts A and B within the HCA required enrollment timeframe.
I'll just add to this prong of the deferral rule would be slightly different than the existing ones in that all of the others do require you to prove comparable type of coverage, and they were designed so that you had some level of comparable coverage to what exists within the PEB portfolio today. One of the challenges, and we wanted to not make this overly administratively complicated for everyone, is we didn't think it was ideal for the healthcare authority to be in a position to identify and understand national health systems or local health plans that exist worldwide, especially when we're talking about a relatively small number of individuals. So this is designed to kind of eliminate having to, compare the national health system in the UK to PEB program or a local governmental plan in Madagascar. Yes, we have members in Madagascar. I don't know if they're retirees, but we have members in a variety of different countries. And we just didn't think it was worth that challenge. So we decided to recommend to you bootstrapping to when a person comes back to the United States, if Medicare lets them in, we'll let them in too. And that's kind of fundamentally what this is saying.
Slide, please.
Questions?
Is it just me? If someone's coming back, how could you say they permanently live in a location outside the United States? It's not permanent if.
Well, the permanency, like an individual, I think the individuals that are out right now have been there for many years.
Yes.
And then they change their residency, repurchase, or they physically move and declare residency essentially back in the United States. So they're, I guess I could kind of understand. It's like nothing's ever permanent,
Okay, yeah.
Well, there's one thing. Got the taxes, maybe two.
Okay, I just, it just seemed a little inconsistent.
You permanently live there until you change. And so, yeah. What we're trying to distinguish is people who go overseas for a few months or something like that.
Yeah.
the Medicare rule is more than 6 months
Correct.
outside of the country, so
Yeah.
that's to get at this.
Thanks, Ellen. So the second proposed resolution, PEB 2024-27, addresses all Medicare enrollees who are enrolled in UMP Classic Medicare with credible drug coverage who permanently live in a location outside of the United States and did not make an election during this annual open enrollment. They will be automatically deferred with an effective date January 1st, 2025. The proposed board resolution is necessary to give HCA the authority to auto defer all Medicare enrollees who didn't make an election during this annual open enrollment. And it reads, proposed resolution PEB 2024-27, automatic deferral, PEB retiree insurance coverage for Medicare subscribers who permanently live in a location outside of the United States. All Medicare enrollees who are enrolled in UMP Classic Medicare with credible drug coverage as of December 31st, 2024, and permanently live outside of the United States where the subscribers did not make an election during the PEB annual open enrollment period held in 2024 will be automatically deferred from PEB retiree insurance coverage with an effective date of January 1st, 2025. These subscribers will be exempt from the deferral form requirement.
So operationally, we have about 20 people who are in this scenario. We'll communicate with them as open enrollment's coming. A subset of them inevitably will not make an election, and we're saying let's automatically transfer them. I just want to remind the board, there really isn't another option other than to auto defer them, because if you look at the portfolio as it exists in 2025, United Healthcare has Part D, so can't be in there. UMP Classic has Part D coverage, can't be in there. There's a similar prohibition on Plan G, even though it doesn't have drug coverage, there's a comparable type of limitation enrollment. So possibly the answer could be Kaiser, but that's not international coverage. So the only thing to do is to keep these individuals, have them hold their spot in line to one day maybe come back in and maintain their eligibility for benefits, but there really isn't any other choice of where to put them. They don't have a plan option to pick. But we wanted to make sure that they retain the right to stay in the portfolio.
So next slide, please. So the next steps are we will incorporate any feedback from the board in the proposed policies, and members of the public can submit feedback to HCA PEB SEC board policy feedback at hca.wa.gov by June 20th. And we will bring the recommended proposed policy resolution to the board for action at the next board meeting on June 27th.
And Stella, typically you send out for stakeholder review right after the board meeting or within the next day, but I think I asked you to start the stakeholder review process once the materials became published earlier this week, because it is a shorter timeline between now and the next board meeting. So just wanted the board and the public to be aware that we started that process a few days earlier than usual, recognizing that shorter timeline.
Thank you very much.
Any questions? Thank you, Stella. Thank you, Ellen.
Thank you.
Next up, we're at public comment. So do we have anyone in the room, a member of the public that would like to speak today? Seeing none. Out in Zoom land, if you could indicate that you're interested in speaking by raising your Zoom hand, we will call on you. Finding their button. All right, seeing none, our next meeting, we've concluded this board meeting. Our next meeting is going to occur June 27th. Same format of attendance, in person or via Zoom. We are going to be going into executive session today after this meeting and then coming back to officially close the meeting. Dave, for the 27th, what do we got lined up?
Preview of coming attractions. We may start off the meeting with a brief executive session after calling it to order, depending on if there's any final things with rate setting to share that are proprietary before the unveiling of the public rates, which will be on the 27th. We're actually anticipating this year of doing publicly the rates for both Medicare and non-Medicare at the June 27th meeting. In recent years, we've kind of frame shifted, and we started with Medicare. At the next meeting, we've had the board approve Medicare, and then we've introduced non-Medicare, and then had a third meeting. But the way the negotiation process has gone this year, we think we can actually move up the non-Medicare piece and do them at the same time. So all rates we're anticipating to do the public presentation of them at the next board meeting. We'll also ask you to take action on the 2 resolutions that Stella just presented. And alongside of those rates, before the rate presentations, we'll have a presentation by the contract managers that oversee procurement to talk about the benefit changes that could that are wrapped into the rates that will be presented. And then last but not least, it's time to talk about 2025. So we'll give you the proposed board schedule.
Any questions for Dave? All right, we're going to transition to the executive session that's going to happen here in the Sue Crystal room for board members and including HCA employees. At this time, members of the public joining us in person at HCA today, as well as employees not part of the executive session, will be asked to go to our lobby for the duration of executive session. You'll be called back to join us in Sue Crystal for the remainder of the public meeting. It's just going to be a very brief statement to formally adjourn the meeting after exec session is concluded. So pursuant to RCW 42.30.11L, subsection 1L, the board will now meet in executive session to consider proprietary, confidential, non-published information related to the development, acquisition, or implementation of state purchased healthcare services as provided in RCW 4105.026. The executive session will conclude no later than 2 o'clock. Board members, let's go ahead and take a quick break while we transition to exec session, and we will return to the public meeting to adjourn afterward. Thank you. Okay, folks, we're coming back from executive session and we're going to go back into executive session. We're extending our time no later than 2:20. Thank you. Hey, everyone, we are returning from executive session for the second time, and this meeting is now adjourned. Thank you. Did we get the people on?